speak up if you're active. Yeah, I want active people over here. Otherwise, I'm not teaching. I'm leaving. I'm leaving. I want you to be active.
No, please.
Great. We have Aksa. We have my fave student since class 1, day 1. She's active. Guys, be like Aksa. Yeah, where are other participants? I'm Dr. Hasna here, by the way, guys. I don't teach without activity in the class because these classes are not for me, they're for you. So I have to make sure that we are on the same page. There's Oh, okay. I see someone's here. Dr. Zara's here. Okay, so our day 1 attendees are still active. Aksa and Zara noted in my mind. Well done, guys. Where is everyone else? Where is Summer? Where's our previous attendees? Where are our previous attendees? I'm not teaching without activity because psychiatry is a difficult one. Sorry, guys. I'm just, yeah, present. Okay, let's go. So, what we're going to do is basically in psychiatry, what we're trying to do over here is that we need to get to the level of the patient. There's going to be different types of cases. As I taught you all that there's a basic structure that everybody needs to follow. Okay, the basic structure goes like rapport, complaint, and all of that, right? But in psychiatry, with every different disease, your structure will change. Depression has a completely different structure. Schizophrenia has a completely different structure. You have anxiety attack, you have ADHD, you have memory issues, you have somatoform disorder, you have postpartum depression, you have suicidal attempt. All of these have different structures. So today, all of you will memorize with me the different structures. So nobody's going to be sitting. Why the heck does this person keep messaging me? I'm sorry. Okay. Okay. So what we're trying to do is we're going to memorize the structure while you're in the class. Okay. So that you don't have to go home and do all the boring work, right? So psychiatry is one of my favorite topics, and it's one of my hardest worked topics because I worked hard on it in order to make it easy for you. And I hope everyone can see my board. If you can't, let me know. I understand that some people are like at work, so they can't really do much, but that's totally fine. Like, even if you're at work, but you're at least listening, even that's a huge deal. It's not a tiny thing, okay? So well done. A huge shout out to the people that are at work and they're still trying to manage this. Okay, I hope if anyone cannot see my board, also let me know. Thank you, Summer, for letting me know. That's sweet of you. Okay, guys. Once again, you guys have paid for this classes. You have the complete right to be the one to tell me that, hello, hi, I cannot see the board. I cannot do this. So, you guys paid for this class. I have to work like 10 times harder because everybody's, pennies over here. I can't, my purpose is that every penny you spend should become worth it. Okay. I should make sure that all of you feel like it was worth it spending money here. This is my duty to do. Okay. And I want everyone to participate today because psychiatry is going to be fun. And I want you guys to even like show me your best, what do you call it? Your best IPS. I'm going to help. Everyone's going to practice today. Okay, let's begin with the first case, begins with the depression. Okay, let's learn the structure together. I'm going to ask the structure at the end that, okay, tell me, what did you learn? Okay. So everyone, the structure for depression goes like this. First of all, whenever someone's like this, and you're just like, could you tell me what's going on? They'll probably not even complain about the fact that they're low. They'll just say, nothing, doctor, I haven't been sleeping. Or whatever it is, you will notice it in their non-verbal cue. So what I want you guys to do is learn to identify non-verbal cues when someone's like that. Please don't ignore it. Please acknowledge everything. From yesterday's class, I told you guys to always acknowledge everything. So how do you do that? I can see you're a bit uneasy. I can see you're looking a bit low. Is everything okay? So I want everyone to have their own dialogue prepared on what they will say when it comes to someone being low. So I want someone to open their mic and try it with me. Wow. So, honey, the people that are gonna try over here are gonna be okay. Aksa wants to try today. Well done.
Yeah.
Aksa, go ahead. This is me. Yeah, doctor. I haven't gotten sleep.
Yeah, Hasna, I see that you don't look very happy. Is everything okay? Do you want to talk about it?
That's brilliant, guys. We need to be like Aksa. That was beautiful IPS. Aksa, when's your exam?
It's embarrassingly near. It's on 17th of June.
Oh, then it's perfect that if you have good IPS even now, it's perfect. So, you're already, if you want to give the exam, you can give it right now because that was beautiful. Okay. So, ready? So, what do you do in depression? Always go for, I can see you're a bit low. Everything's okay. Just like Aksa said. Is everything okay? Yeah, doctor, everything's fine. If she is not admitting to it, you know what you're gonna do? You're gonna do that first question to ask when someone's depressed is tell them to score their mood, and that's it, you'll get your answer. The moment someone scores their mood below a 5, you have to go to this structure right over here. This is the depression structure. Okay, so once they say, doctor, I'm 3. Okay. All you have to do, your brain should go out and take out this structure. So once again, for anyone that's new, in Plab 2, your brain is a library. Library consists of books. Books are of different structures. That's the whole purpose of the Plab 2. You should have memorized the structures rather than just big treatments and big diagnosis and all of that. Okay. So how do you do that? You're going to do it like this. Okay. And you're not going to memorize any dialogues or lines. You're going to memorize this structure and you're going to make up your own lines. When someone says their mood is low, you're going to say, oh, I'm very sorry to hear about that. Number one, significant event. Is there anything significant happened before you started feeling this way? Yeah, doctor, I lost my dog. There might be a significant event. Yeah, doctor, I actually like my husband left me or something happened. I got abused. Maybe it becomes a domestic abuse case from right on here. Okay. So if she says, doctor, my husband kicked me, maybe she says that. You know what you're going to do? You're going to activate your brain and you're going to go to that library and you're going to look for the domestic violence structure right there. My husband kicked my tummy. Okay, let me go on Dr. Hasna's board, locating. There's the domestic abuse. And then you begin with this structure. Empathize. Oh, no one should have to deal with that. Could you tell me what's your next plan? Could you tell me the EVP? You get what I'm saying? So your brain during Plab 2 should be a computer. And that's what I'm training you to do. My purpose over here with these classes is somehow train you to think like that, like this. You should know what to say instantly. You should know exactly what questions to ask. So the moment someone says their mood is less than 5, you go to like my board and you go like a computer. You're like processing. Here's the structure. Go. Okay. Did any significant thing happen before this? No, doctor. Nothing happened. Okay. Uh, how would you say you're feeling? How frequently do you feel? No. Would you say that in the past month you've been feeling low or down quite frequently? Because it's not one day diagnosis. Has it been happening in the past month, past couple of months? Yes, doctor. Which means it's depression diagnosed. And then you can ask another question. Would you say you've lost interest in things you used to enjoy once? Yes, doctor. So now you know that this is definitely a case of depression. So what are you going to do now? What is your purpose after that? Guys, listen, these questions are not for no reason. These questions are for us to reach our exact specific diagnosis. What's the purpose of asking the further question? Is to diagnose whether it is mild, moderate, or severe depression. You get what I'm saying? So either it's mild, moderate, severe. How do you know it's mild? How do you know it's moderate? How do you know it's severe? Your questions will help you do that. So I have made this structure very strategically that it will help you like a computer. You'll be able to solve. If she says this, yes, it's a moderate. If she says no, it's a severe. So this is going to help you a lot. Okay. So once she's answered these questions, now you go to the further questions. You ask, oh, I'm sorry, and you're telling me that this has been going on for the last 7 weeks or whatever, 1 month. Could you tell me how has it been affecting you? For instance, your sleep. Doctor, I haven't been sleeping good. How about your energy levels? Doctor, it's very low. How about your weight? Did you notice any fluctuation in weight? Yes, doctor. How's your concentration? Do you feel guilt over things? Yes, doctor. And how about your appetite? How's that, doctor? Either she'll say I'm eating a lot or eating very less. One of the two, both are depression. Would you say you've been feeling restless? This is called psychomotor agitation. Sometimes your hormones get messed up in depression and then you just feel restless and okay. So, however, once again, guys, I'm telling you this since day one. You're not supposed to ask all of these questions, honey. You don't have that much time in your life, okay? So you're not gonna be like, okay, can you tell me about your sleep? Okay, now tell me about your energy. Okay, now tell me about your weight. Okay, now tell me about your concentration. Time's up, move to the next station, and you failed the exam. No, just one or two questions among these that you feel, okay, she's already said that she has sleep issues. I don't need to ask about sleep. I need to assess other things. Would you say your concentration is also depleted? Yes, doctor. So the purpose of these further questions is if she says yes to the fact that her depression is affecting her day-to-day life, it's definitely moderate depression. Wait for it. I'll explain it further. Okay. Now coming to our third most important. What did I say, guys? Always remember the ghost with a red flag. Okay, red flag, what are you going to ask in a case of depression? You're going to ask about self-harm. Rather than this is my biggest hack, no need to go directly asking about suicide. Start with self-harm. So always when you're about to say something bad, guys, this is my biggest hack coming through. Everything is my biggest hack, but yeah, one of the biggest hacks coming through. Remember, whenever it's a bad thing, it's a awkward thing, it's a huge thing, always uh, slow down the way you ask it. Ask it or tell it. For instance, you have to tell someone they had a heart attack. It's a bad thing, right? So don't just be like, so what you have is a condition called a heart attack. You can't do that, right? So whatever. So from what we've seen, I'm sorry, Michael, it seems like this is a heart attack. So take a pause. Who's gonna try it? Come on with me, guys. Who's gonna try it? Tell me that. Tell someone that it looks like a case of ovarian cancer. Who's gonna tell me? Open your mic and do it, guys. Whoever practices here is a lucky person. Go ahead, Aksa.
So, Hasna, as per our discussion, it looks like you might have had a heart attack.
Okay, no, that looked like you're happy about it. No offense. So
Okay,
what did I
okay.
say? Take a pause before you say the
Mm-hmm.
heart attack, and make sure your tone is a bit low. It's not
Okay.
happy. Yep, okay, go ahead.
So, Hasna, it looks like you might have had a heart attack.
Okay, so Hasna, from whatever I gather, um, it seems like that this is most likely a heart attack. So it's like very sad. You're sad, you're
Hmm.
low.
Hmm.
Okay, try again.
So, Hasna, as per our discussion, it looks like this could be a heart attack.
Okay, good. That was better. So what I'm trying to do is that, guys, I am here. I am here. All my hours are dedicated to you. If you perform however you perform, I'm going to sit here and I'm going to wait for you to do it perfectly. I'm not going to leave. Okay, so take your time. You paid for this, you deserve this. Okay, you deserve all my time. So take a pause before you say something difficult. Well
Mm-hmm.
done, Aksa. Well done. Okay, everybody who would like to try, go ahead and try.
May I?
Go ahead. So you're going to tell me that this is ovarian cancer. Say it in your own words. Don't use my dialogues.
Uh, okay, Hasna. So, after all the chat we had, I'm really sorry to tell you that it could be an ovarian cancer.
Very good. So I like the way she went a little slow and her tone, her speed and her volume goes down. So point over here is whenever it's a bad, depressing, scary news, I told you guys the three important things to remember. Number one, slow down your speed and your volume. Number two, take a pause before the big bad thing. And number three, lean in forward. These are three hacks to nail your IPS. I've taken an IPS workshop, and in that, I taught you guys this. Many people took it. I don't know who took it over here or not. But the point is that even if you didn't take it, now you know. So lean in forward. It seems like it. we're suspecting that this is a, take a pause before it, heart attack. Okay, so it's not a good news. So you're about to ask her about self-harm. Okay, now listen to me very carefully. I'm introducing a new term to anyone that's new. The new term is called signposting. Does anybody know the definition of signposting?
So is it some sort of warning which we give before we like actually come to the
Very
point?
good. Very good. So guys, remember, what is signposting? Warning. Giving a warning to someone, but not like in a nice way, that I'm about to ask something, or mentally preparing someone that I'm about to ask something awkward, something difficult, something intense. So when do you signpost? When you're about to ask something very intense. So signposting is just warning someone that I'm about to tell you. Okay, so for instance, for self-harm, remember, this is IPS hack. If you don't signpost, your marks go down significantly in IPS. Okay, so what do you do? How to signpost? And I'm sorry to ask this, but it's just a part of standard protocol questioning. Alexa, did you ever maybe have any kind of thoughts of hurting yourself? So you see, I'm following speed going down, volume going down, leaning in forward, taking a pause before breaking it. So it's like signposting is a mini BBN. Okay. So whenever you say anything that's intense, bad, awkward, signpost. All of these things are signposting that I just taught you. Okay. So what are you gonna? So self-harm question should be asked with signposting. If you ask without signposting, and if the patient, exactly, thank you, Zara. That was amazing. This is the word I was looking for. Disclaimer. Love it, love it, love it. Disclaimer is the word. See, you guys complete me. Well done. So who's gonna tell me? Who would like to try a signpost and asking me about self-harm? Anyone that gets to participate in this class, they're very lucky people, because you know the people that actually participate are the ones that become, that get the most benefit out of these classes. Okay, so take a, like, there should be like a, what do you call it? There should be benefit of taking a live class. Live class benefit is this, that you can practice live. That's what I want. Okay, ask me, Aksa, about self-harm.
Okay. So Hasna, I am really sorry to ask you this, but this is a part of our standard questioning. Have you ever considered harming yourself?
Very good. Okay, good. Love it. So just the thing is that before you say the harming yourself, I want you to slow the harming.
Okay.
Maybe harming yourself, like, oh, hurt, like
Hmm.
it should. Oh, this is a bad thing. I'm very sorry to ask this, but I have to ask this. Okay, go.
Hmm. Bit of awkwardness should show, and there should be like an audible pause.
Yes. Because I feels like you're happy. Okay, like although like it's not that you're doing good, but I feel like you can do better because this is a sensitive situation.
Mm-hmm. Mm-hmm.
Okay, anytime, guys, the patient makes this face, like, what kind of a question is that? Like, if he makes, like, does this, your IPS goes low. That's what I'm scared of. Okay, so, and I'm sorry to, just like Aksa did. Aksa did the perfect signposting. I'm sorry to ask about this. But this is a part of our standard protocol question. Did you ever maybe have any thoughts of, harming yourself? And you're very stressed out for him. No, doctor, nothing like that. Okay, so red flag. Well done. Okay, now let's go to the next part of the question. So now we're done with the main complaint. We are exploring the complaint like this. This time in depression, in low moods, we don't explore the complaint by OD para by Socrates. In this, we explore the complaint by these questions. Okay, now what's the purpose of these questions? It's time to reveal the best, coolest thing is that if she says yes to the intro questions, she has mild depression, and she says no to all of these. Okay, if she says yes to intro plus further questions, she has moderate depression. And if she says yes to the red flags in addition to all of this, it is severe depression. And with these three important levels, we get to know how to manage the patient. So there's a purpose of making a structure like this. Okay, this is why I wanted you guys to take the psychiatry class, because these are my best structures. Okay, so if it's a mild depression, the treatment is only talking therapy, nothing more. Okay, I'll send you in for a talking therapy. There'll be a therapist. You're going to feel better, blah, blah, blah. Okay. And then you have, if she says it's moderate depression, then you have to do CBT plus consider antidepressants. But if the red flag comes out to be positive, I'm sorry to tell you, but you have to be either admitted if you're in the hospital. If you're in the GP, then immediate referral to the hospital. You cannot send a person with a red flag positive. So guys, whenever a red flag is positive, send them to the hospital. Don't forget this. Red flag positive, send to the hospital. Write it down. Okay. Now, what are the rest of the questions we need to ask? We need to ask about famish. So usually psychiatry history is not PMAFTOSA, rather it's famish. In psychiatry, we take the biography by asking famish. Give me a second. Okay. The reason we do famish is because it's a little different than the normal questioning. PMAFTOSA is for normal, like non-mental health issued people, but famish is for mental health issued people. Okay. F for family. Anybody in your family? Friends. Have you talked to it about your friend with your friends? You know, how are you feeling? Financial. How are you doing financially? Maybe financial is the issue which he has problem with. Maybe forensic. Like, do you have any problems with the law? These are obviously we don't have that much time in 8 minutes to go through this, but guys always know things. That my point is that in life, if you want to progress, know everything, even if it's not the most important thing for your exam, but know it. If you know it, you're someday or the other, if you're doing an extra effort, it will come and stand in front of you and give you all the benefits in the world, right? So A is for addiction. Okay, because in psychiatry, that's the issue. A for allergy, you can ask. M for medication, medical history, mental health issues in the past. M. Okay. I is for insight. Who knows the definition of insight?
So insight is when you know that there's a problem and you know that there is a need to get help.
Very good. So being aware is being having insight. Okay, well done, Aksa. So insight, if someone does not have an insight, that's a freaking red flag. If she says that, no, I don't think I need help, I need to admit you to the hospital, honey, because you're screwed. Anyway, because if she doesn't have an insight that she's feeling low and it's bad, and then what if she just suicides and thinks that's completely fine to do that? Coming to S, S is for suicide. Once again, we've already asked that in signposting. Even just ask self-harm. If she says no to self-harm, probably suicide is a no. If she says yes to self-harm, then go and ask the suicide question. H is for hallucinations. And I'm sorry, sometimes when people are going through a difficult time, they tend to see things that are not there. And I'm sorry to ask that. Is that the case for you, Mr. Alex? No, doctor. Okay, that's good to hear. Now, what is this? Smoking, alcohol, recreational drugs, SAR. This is something I made myself, okay? SAR. And always ask ICE. ICE is this, what do you call it? ICE is a questionnaire that you need to do in UK. In NHS, ICE is very important. Ask the person's idea, ask their concerns, and ask their expectations. This is a whole like questionnaire situation, okay? That you should always do. But in my classes, I teach that ask the idea in the history taking part, ask the concerns in the treating part, because you know you cannot give in the questioning part. So why the heck would you ask his concerns, right? So just ask idea. What do you think that it could be? Concerns, asking treatment. Doctor, my concern is that I don't want to get admitted. My concern is I don't want drugs, whatever it is. Okay. So you can even give him address. However, the E part of the ice, I say, skip it. There is no way you can fail. There is no way. Like write it down, make me write it down or whatever. You cannot fail if you don't say the expectation part. Okay? Okay, treating. Okay, so if it's mild depression, thank you so much for talking to me, Alexa. It seems like, you're telling me that you've been feeling low for the past couple of months, and you even told me you lost your dog, and I'm very sorry to hear about that. Alexa, from what I gather, it seems like you are having what we call mild depression. Are you following me? It's most likely because of the, loss of your dog or whatever it is. Are you following me? Yes, doctor. Okay. Depression is just a type of feeling low and losing interest in things you enjoy. And when it starts impacting your day-to-day life, that's when we call it clinical depression. Does that make sense? Yes, doctor. Okay. Would you like to know what we'll do for you? Yes, doctor. First thing, I am going to refer you for a talking therapy. It's known as a cognitive behavioral therapy. You talk to the therapist, and talking really helps. Like you guys make up your own script for talking therapy. Like it organizes your thoughts. It makes you feel a lot better. It makes you speak about what's going on. And, it 100 times it affects our patients a lot. It helps our patients a lot. Okay. How does that sound to you? Doctor, I think it sounds good. All right. And apart from this, at the moment, Alexa, I just want to give you some basic advice. Try to exercise, try to talk about it with your friends and family, and this will resolve. Or whatever you want to say to her, be very nice to her, be very sweet with her. Okay. Are you following me? At any time, Alexa, don't forget your safety netting, guys. The ghost, how dare you forget the ghost? At any time you feel like, you know, it's getting too overwhelming for you and you're getting too low, please come to the hospital immediately. Are you following me? Yes, doctor. Okay, would anybody like to try to give me your best expression for the treatment of depression? Go ahead. Okay, shy people, I want you guys to try to. Don't stay behind the, what do you call it? Mute mic. It's your safety place. Get out of your comfort zone. Plab 2 is all about getting out of your comfort zone. The more you get out, make mistakes, make it in front of me. Nobody cares over here. I'm not going to judge you. But don't make mistake in the exam. Okay, it's totally worth it to make a mistake over here. Totally worth it to perform bad over here so that your exam gets better. So go, 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 go. Who's going to try? Once in a lifetime opportunity. Okay, Summer. Summer's like, you know what? That really convinced me. Whatever Dr. Hasna says, she's right. Oh my God, why am I shy and hiding behind my mic? Okay, go ahead.
No, I actually I have a kid with me, so that's why I'm just affected all the
Hey
time.
guys, that's what I'm saying. Some people are at work, some people have kids, but they're working so hard. They're listening to this. It's like huge shout out. Well done, Summer. Well done.
Mm.
This is hard work. Okay, try.
Okay, Asna, for what you have told me and from what I understand, it seems like you are going through depression. Do you know about depression?
Yeah, I have an idea, doctor.
Yeah. Actually, depression means feeling low and losing interest in things that you used to enjoy, as you said. And these symptoms have severe impacts on your daily activities. So I want to give you an advice to I want to refer you to the psychologist for talking therapy. It really helps. How does that sound?
No, always, guys, before you go to the treatment, first ask her, once you've told her the definition of depression,
Okay.
okay, am I making sense to you? Yes, doctor. Okay, would you like to know how I can treat you? Yes, doctor. Go for psychiatry, whatever, CBT, whatever. Okay, so make sure as much as you can break it down, give her food like that, you're
Okay.
gonna do amazing. But that
Okay.
was good. That was very good for someone who you're doing this for the first time and you did it very well. Okay,
Thank
just
you.
make sure your volume is also like you're a little sad for, and also you should show some concern. And I'm very sorry you're going through this. And
Okay.
Most likely because you are telling me your husband left you. I'm very sorry to hear about that. Most likely because of that. Go.
Okay.
Well done, Samar. So then you just give her some advice on lifestyle and then you safety net her, and that's how you do depression. Okay. Now coming to antidepressants, we need to learn some rules. Okay. Antidepressant has some rules going on. What are the antidepressant rules? Always remember, if you prescribe an antidepressant on your own, you'll fail. Okay. Because this exam's priority is safety doctor, safe doctor. You got to be a safe doctor. So how can I be safe? Number one, ghost with a red flag. I need to ask red flag questions, and I need to scare them, which means I need to safety net them at the end. Okay. What are the tiny things other things that you can do to be a safe doctor is involve senior when you're prescribing antidepressant. Let's talk about the antidepressant rules. Memorize these rules with me. Okay, majority people, we give sertraline as an antidepressant with our senior. Okay. If someone says, doctor, I have a problem with my sexual drive and I'm worried it will affect it, then you say, it's okay, I can help you with that. We can change the antidepressant. We can give you reboxetine because it has less effect on that. How does that sound? That sounds good. Okay, I'm just going to call in my senior and then we're going to prescribe you this. Okay, are you following me? Yes, doctor. Okay, so these are the antidepressant rules. Now, most important safety netting rule of antidepressant. Oh my God, this is intense. Okay, ready? This right here is the golden words to, if you don't, then it's over for you. I'm sorry to say. Okay. You have to tell her that, okay, we are going to prescribe you antidepressant. I'm going to call in my senior to do that. However, Maria, I want you to know that antidepressants take about 4 weeks to actually give you an effect. And in those 4 weeks, you might even feel worse. But just remember and just be patient that this is very normal with the antidepressant. Okay, but in no time, you'll start feeling better. Are you following me? Yes, doctor. So, guys, this rule is important because if you don't tell her this, you know what's going to happen? I'm sorry. So, when she'll start taking antidepressants, this is psychology. This is what's going to be going on in her mind. Psychology is her psychology will be like, she's taking antidepressants. She's like, oh my God, I feel even worse. Like, what the heck? Even antidepressants are not working on me. That means there's no point of living in this world. I'm sorry, please. I really hope I don't get into trouble for this. Okay, so that's what I'm trying to explain to you. Okay, guys. So, uh, antidepressant rules, very important. You have to tell her that it takes a while for it to get affected and you might even feel worse during it, but always remember it's very normal in our therapy for this to happen. Are you following me? Yes, doctor. So who would like to tell me the 3 antidepressant rules?
Let me try.
Go ahead. Who? Yeah.
Okay, so the first one is that you must involve your senior in prescribing
Very
antidepressants,
good.
and
Very good.
then when the majority will prescribe sertraline, but when there is a complaint of sexual issues, you prefer to prescribe ribosatine, and
Very
then
good.
use safety net. You tell them, let them know that it may not work in the first 4 weeks. It may take 4 weeks for the effect to begin to show. They might even feel worse, but they should keep on taking their drugs.
Brilliant. Now Dr. Kuye is a safe doctor. Well done, Dr. Kuye. I believe Dr. Kuye usually is at work, but I really appreciate that she opened her mic and participated. That means a lot. And is going to help her a lot. Well done, Dr. Kuye. So now we all know the antidepressant rule. Who's going to tell me the structure of depression? We are summarizing depression now. Who's going to tell me the questions of depression? Aksa's opened her mic. She's like, no one's going now. It's me. It's my turn. Okay, go ahead, Aksa.
Ouch, it was like, I think it was like a wrong tap at the wrong place. Okay, so am I supposed to like go through with the structure?
Yeah. Tell me the depression structure.
Okay, first of all, we have three kind of questions: intro questions, further questions, and the red flag questions. And this helps to memorize them. So, intro questions would be first we implore their mood. That's
Very
how
good.
we like reach the depression thing. That like, leads us, okay, that this is going to be a depression scenario. So, intro
Very
questions would be: was there anything significant in the recent past? Have you been
brilliant.
feeling low a lot lately? Have you lost interest in the activities that you used to enjoy? And then if they say yes to these, we already have a mild depression case right there. Then we proceed to the further questions. So if does this affect your sleep? How is your energy lately? Have you had any problems with your weight? Do you feel any problems with your concentration? Do you feel guilty often? uh, is your appetite okay? Um, and these were the further questions, which means that if they say yes to these questions, they have moderate depression. And then we
Very good.
proceed to the oh thank you then we proceed to the red flag questions, and we do signpost, and we like go slow, low in volume, lean in, and we ask, and then if they says yes to the self harm and they don't have any insight, so we matlab label this as like severe depression.
Done. What's next?
um uh Famish.
Yes, famish. Very good. What happens after famish? Nothing. Very good. How do you treat?
So if it's mild, if they say or said yes to the only the intro questions, it's only CBT. If it was moderate, CBT, the talking therapy, we say talking therapy to the patient with drugs.
Very good.
And if it was, if they said yes to any of the red flag questions, and then we admit. And if we are in the GP setting, we refer them to the hospital, and we convince them to like go to the hospital right away.
Wow, everybody, if we were in a real class, I'd make you all clap for her. That was amazing. Amazing. That is how you need to be thinking in Plab 2. Only this much. This is what should be in your mind, not extra things like 20 million questions of depression. What was the 220th thing that Moshobi wrote in his notes? Wait, what were, no. Simple. Keep it simple. Only talking therapy. Honey, okay, Aksa, could you tell me how you're going to tell me about the talking therapy? I would like to send you to talking therapy.
Okay. So, Hasna, as per our discussion, it looks like you have a condition called mild depression. Have you ever heard about it?
I guess.
Okay. So, there are ways we can help you. Can I go through with them?
Sure, doctor.
Okay. So, Hasna, at this point, I believe that talking therapy can really help you, and we've seen our patients benefiting from it. This is the place where you go to the physician, you talk to them, you go through all the problems, you can have discussions with them, and then you can like really organize your thought process, and you can get things into perspective, and we've seen patients benefiting a lot. So how does that sound?
Okay.
Okay.
Doctor, can you give me drugs? Can you give me some antidepressant?
So, Hasna, at this point, I believe that you would not really benefit from antidepressants. So, antidepressants have their own side effects and their own problems. So, at this point, I think we shall just go through with the CBT, the talking therapy.
Very. So basically, that was a concern of the patient that Aksa addressed so perfectly. Okay, so well done, guys. This is how you do depression case. So Aksa nailed depression because she wasn't
Thank you.
depressed. I'm just kidding. So well done. You can
Thank
only
you.
nail depression if you're not depressed, but like well done, Aksa. So her your exam is close, and I'm proud that you are at this level of your prep. Guys,
Thank
usually
you.
you get to this level at least 10 days before your exam. You only the real improvements happen when you get 10 days
Mm-hmm.
before 10 days before your exam. That's when you actually see the change in you. The way
Mm-hmm.
you speak
Mm-hmm.
is beautiful. But someone who's doing it right now, it's a big deal. It's a huge deal. So well done, Aksa. So proud of you.
Oh, thank you. That will really helps. Thank you.
So well done. Now let's go to another variant of depression. She's going to present with an insomnia, right? So if she presents with insomnia, and then when you do the sleep history questions, you will find out her mood is low, then you go to the structure and do the same thing. Got it? Another variant of another invariant of depression is postnatal depression. In postnatal depression, same structure. All you need to do is just add these questions and be excessive sensitive. Okay. Now, in postnatal depression, you have to do what? Two signposting. First, before you're going to tell her that I'm about to ask you some sensitive questions, please bear with me. If you get uncomfortable, you can ask me to stop. One signposting done. I'm sorry to ask this, but do you think you're a bad mom to your baby? And I'm very sorry to ask this. Do you think there's something wrong with the baby? So I'm sorry to ask this is also a form of signposting. Okay, so you're warning, you're disclaiming them that, oh my God, I'm about to say something intense. So first signposting is before you ask the questions, and then tiny signpostings before you ask, yeah, the each question. Okay, so this is the signposting package that usually happens in postnatal depression. The most signposting you can do is in postnatal depression. Okay, so anyone that's had a kid would understand that these are sensitive questions. Okay, so what you're going to do is, could you rate your mood for me? Doctor, it's 4. Oh, did any significant happen maybe since you've been feeling that way? Doctor, actually, I had my baby and I don't, and instantly, shoot, she had a baby. When did you have your baby? Doctor, just right now, month ago. Oh, and how is everything going? Is everything okay with the baby? Yes, doctor. Okay, I'm gonna ask you some sensitive questions, Alexa. Please don't mind. If you want me, I can stop anytime you feel uncomfortable. Is that okay with you? Yes, doctor. All right. So, Alexa, have you ever been feeling perhaps like maybe you're not a very good mom to your baby? Anything like that? No, doctor. Yes, doctor. Okay. So postnatal depression, she'll say, yes, doctor. That's exactly how I feel. I feel like a very bad mom. Oh, I'm sorry to hear about that, Alexa. And has it ever occurred to you, maybe sometimes, that you feel like there is something, maybe something's wrong with the baby? Yeah, doctor. Sometimes I feel like the baby is just too much for me. I understand. This can be an overwhelming time. I completely understand. So keep acknowledging what she's saying. Don't just be like, yes, doctor, I feel like the baby is too much. And you're just like, okay, next question is blah, blah, blah. Don't be a robot. Acknowledge. She's like, oh, I can understand. This is a very overwhelming time for you, Alexa. I love you. Okay. Like be so fake that you fake the love. Like that's how much it should be. Like, I love you, Alexa. Okay. Now, the most important red flag question in postnatal depression is asking about harm, but this time harm to the baby is the red flag question. So, Alexa, I'm very sorry to ask you this once again, but just a standard protocol questioning we need to ask, okay? Have you ever had any kind of maybe thought of, I'm sorry to ask this, harming your baby? No, doctor. See, this is why I say very sensitive. So I think postnatal depression wins in the case of sensitiveness. Okay, so the most sensitive, I believe, even beyond any sexual history question, any other erectile dysfunction, even, I feel like postnatal depression wins. And postnatal depression is actually a difficult and more sensitive scenario. Okay, and the final question, please don't signpost for this. You just ask her, are you breastfeeding your baby? So, 4 postnatal questions you need to ask in your depression structure. Number 1, do you feel like a bad mom? Number 2, do you think something's wrong with the baby? Number 3, I'm sorry to ask this, but do you feel like harming your baby? And number 4, and are you breastfeeding him currently? Yes, doctor. If she's breastfeeding, the significance of breastfeeding is that our medicine will change accordingly. And the only treatment, and then if you want, you can add on some questions from over here. Okay, and have you talked to anyone? How's your husband? Is he supportive? You can ask about smoking, alcohol, and all of these. It's up to you. You can ask, but the most important part of the structure is over. Then it's up to you what you want to ask according to how much time you have. Now coming to the treatment, the only treatment for postnatal depression is urgent referral. Okay, what does urgent? Who's going to tell me what is urgent referral? I think Aksa would know because she's June candidate.
I don't.
No?
No.
Okay. So, Aksa, have you read the notes? Any notes?
I have, and I was just trying to recall, but cannot really. Is it like the same day refer to the psychiatrist?
No, it's fine. I'm
No.
so glad you're attending these classes right now. I'm happy
Mm-hmm.
because very important 2 weeks. When you refer someone to be seen within 2 weeks, it's known as urgent referral. Never forget this in your life, okay? So now, guys, I'm going to introduce you something that's going to be your biggest weapon in Plab 2. That I assure you, go to any academy person, any candidate, ask them to tell you how do you decide when to admit, how do you decide when to send, refer, urgent refer, how do you do that? This is something I'm going to teach you, and I probably will go through this every day because this is gold. Okay, let me explain to you how management works in Plab 2. There are three types of things you need to decide while taking history of a patient. Three things you should have decided. Number one, while you're questioning, you should have made a decision. Do I need to discharge her? Do I need to admit her? Or do I need to refer her? Okay, and I'm going to keep asking you questions regarding this management I've made. This is a best short form I've made in my life. Okay, no, that's too much. Okay, so discharge. Do I need to discharge her or not? When do I discharge a patient? When I feel like she's safe, she's good to go. She's red flag negative, she's good, it's just a tension headache. I'll just make sure when you discharge, you just safety net. That's all. Now, number two, what do you do? When do you do an admission and when do you, okay, we always admit simple when red flags are positive and you are standing in an ER or you're standing in a hospital, you admit the patient if he has red flags positive. Now, coming to referral, what you need to know is that there are three types of referral in Plab 2. The first type of referral is a routine referral, which it doesn't matter how much time limit. It's like, okay, maybe you'll be seen after 2 months, maybe you'll be seen after 4 months. Routine referral is when you discharge the patient, but maybe he needs some ENT specialist also. He can go to a specialist just in case, okay? But red flags are negative, okay? Then you have the second type of referral is known as the urgent referral. Urgent referral is known as the 2 weeks wait referral, that the person should be seen within 2 weeks of the day that we saw him today. And finally is the immediate referral. Immediate referral is for red flags positive and you're sitting in a GP setting. So if we were to combine the two, the discharge can be combined with a routine referral. The patient has red flag negative, we can do discharge him with safety netting. Maybe he needs like to lose weight, so I'll refer him to a dietitian. Routine referral. These are all routine referral. Maybe I'll refer, doctor, also I'm feeling like my legs aren't moving. Okay, I'll refer you to the physiotherapist. Okay, these are routine referrals. Okay, how about, okay, doctor, I also feel like my stomach's gurgling. I just feel like, okay, you're like, okay, I'll refer you to a gastroenterologist. These are routine safe referrals. Just make sure you safety net before that you discharge them. So discharge is usually followed or combined with routine referral. Now, coming to admission. Admission can be the same as immediate referral. It's the same criteria. The only difference is when you're in ER, you admit. When you're in GP, you immediately refer to the hospital. I hope that makes sense. Okay, and it's basically right the hell now. Right the hell now. Get him to the hospital before he kills himself. Okay. And finally, urgent referral is a category that's a category of its own. It has nothing to do with red flag, nothing. But only a handful of diseases you need to memorize, you need to remember. Only these diseases I need to do urgent referral. What are those diseases? Remember. Number one, what did we just discuss? Postnatal depression requires urgent referral. Number two, most important in entire NHS system, I'm telling you, golden thing. The protocol of NHS system is that, honey, whenever you suspect someone having cancer, it's a crime if you don't urgently refer them, even if it's just a damn suspicion. Only a suspicion, based on just one suspicion, you can urgently refer someone. Cancer. So whenever someone comes to you, okay, I will ask you that. One more thing that we use urgent referral is in inflammatory bowel disease. Just remember these three important, whatever these are. And apart from these diseases, just remember red flag positive or red flag negative. Just tell me this. It's positive. Okay. Are we in ER or are we in GP? We're in ER, in admit. Are we in ER or are we in GP? Red flag positive, GP. Immediate referral. Red flag negative, discharge. Do I need to routinely refer him? Yes, no, whatever. Okay, now you guys are going to tell me it's time for a challenge. It's time for a tricky situation going on. You guys will tell me instantaneously, understand while questioning him, this might be the diagnosis, and what do I need to do? Do I need to admit him? Do I need to kill him? Do I need to love him? One of the two. Okay, ready? Guys, patient presents to you with a 1 month history of, let's make this tricky. 1 month history of lower backache, urinary issue. Okay, so let's suppose it is 60-year-old male. 60-year-old male comes to you, has some lower back going on, lower back ache going on, and he also has some urinary issue, as in he's having hesitation or whatever.
Urgent
Hesitation.
referral
Urgent referral?
for
Why
just
do you guys say it's urgent referral?
prostate. Prostate.
Very good.
Yeah,
Yes.
with the backache. So could be metastatic cancer?
Very genius. Well done. So while normal people that are not as intelligent as you guys would have thought, okay, maybe it's just a basic, prostate BPH. That's totally fine. We can routinely refer him to the freaking, what's his name? That urologist. No, you guys saw he's a 60-year-old age. You guys saw it's a backache. Why is there a backache? How can prostate cause backache? So even if 100% is probably BPH, but it's accompanied by some osteomalacia or something, but still, Aksa and Zara knew that this is suspicion of cancer. Even a slight suspicion of cancer, shut up and do one thing, urgently refer him. Otherwise, I'm not a safe doctor. Well done. So proud of you guys. By the way, it will never be as difficult as this. I make these scenarios very challenging so that I in make you think. Okay. So this is a urgent
Okay,
referral. Well
so
done.
do we have to refer him to the hospital if we are in the GP practice? Or what if
Urgent
the patient
referral.
presents in the hospital?
Very good question. So wherever you are, urgent referral is just a referral to the specialist. Okay. So for instance, a urinary, I would like to urgently refer you to be seen by a urologist, not a routine referral by. Patient comes to ovarian cancer suspicion, I would like to urgently refer you to be seen by a gynecologist. And gynecologist will understand, she'll do the CA125 that she needs to do. Patient presents to you with suspicion of acoustic neuroma cancer. Okay, I would like to urgently refer you to an ENT specialist. So urgent referrals are specialist referrals. They're not hospital referral. Hospital referral is only immediate referral. Okay,
Alright.
next. Ready, guys? So patient has presented to you with so the patient has presented to you with obstructive sleep apnea symptoms. What would you like to do for them? Obstructive sleep apnea.
Routine referral?
Well done.
Routine.
Discharge,
Yes, sir.
which is always followed by routine referral. Well done. Okay, nothing, he's not going to die with obstructive sleep apnea. Patient has presented to you saying that, doctor, I think I'm fine, but she's she has anorexia and she is also having some dizziness, syncopes, lost quite a lot of weight.
So symptomatic anorexia goes to admission?
Urgent referral.
Urgent.
Urgent
Oh my God, guys. Aksa wins, guys. Aksa wins. Brilliant, Aksa. Brilliant. Because, guys, remember these things. I'm telling you these like on fingertip type things, but Aksa is already way ahead of us. Well done, but everybody good. I like it when you try. Now, listen, the fact that you tried, now you're going to learn. Anorexia, when it comes with physical symptoms, it's over. She's so she's so deficient in nutrients that there is no other option but to send her to the hospital or she'll die of nutritional deficiency. So once again, the people that said urgent referral, guys, I told you only 3 diseases for urgent referral. If there was a need for urgent referral anorexia, I would have written it over here. So remember these. Patient has presented to you 45-year-old male complaining of let's suppose having bloody diarrhea, and that's about it. No weight loss, nothing, just bloody diarrhea that's really bothering him. And also he has some low grade fever. That's about it. What would you like to do for him?
Urgent referral looks like IBD.
Yes, well done. Aksa and Kuye, well done. Aksa knows it all. Exactly, because it looks, wow, what just happened? Okay, so it looks like IBD. And can I be honest? The reason we even urgently refer IBD is because it kind of can go towards cancer as well. They have the same symptoms. Okay, so bloody diarrhea and what was the other thing? Low grade fever. These are signs of IBD. But low grade fever also in cancer. Remember flaws? FLA. F was for fever, and diarrhea, change in bowel habits above 40 years of age. These should always be so. The same thing for IBD and for suspected bowel cancer, both you need to urgent referral, because this is going in both ways. And the thing that the doctor will do for both these cases is a colonoscopy for sure. Okay, but you learn that further when you go. Tomorrow, Dr. Azram will teach you guys this stuff. What is this stuff? The abdominal stuff. Okay. Now, next patient has presented to you with redness in her white of the eye. Redness in white of the eye. She's known case of, this is a little difficult. And let me see. She's a known case of rheumatoid arthritis. She's taking steroids for it. Yeah, that's all I can tell you guys. I can't tell you more than that. This is tricky case. But today you learned something because of the trickiness. Who's going to tell me?
I think this is immediate referral.
Okay, Raja thinks it's an immediate referral. Why, Raja? Tell me why.
Because redness in the white part, it is scleritis, and
Very
she's a known case of rheumatoid arthritis, so it's a complication, and it comes with a very sharp pain, and it is threatening to the vision.
Very good, guys. Very good. So, this is one thing I want you guys to never forget. Whenever a patient comes to you with scleritis, if you guys haven't done eye ear cases, this might be a little difficult for you, but it's okay. So, Raja has a good memory. Well done. So, we have, whenever it's a case of scleritis, we need to immediately refer because her eyesight is at danger. Okay. Eyesight is at risk because if she won't die, but her eyesight can die. So, that's like you dying. If any part of your body dies, you're done. Okay, you're good to go. No, not good to go. We don't want to lose you. Okay, so it's an immediate referral. So for eye cases, scleritis is an immediate referral because scleritis can kill your eyes. It can die. So it's like, and another thing is glaucoma that can kill your eyes. So for glaucoma also same thing, immediate referral. Okay, glaucoma can make your eyesight, when eyesight is at risk. Okay, who's going to tell me one more disease of eye that can cause you to have an immediate referral?
Giant cell arthritis.
Wow, that was intelligent. Very good. Exactly. Giant cell arthritis. Well done, Aksa. But there's one more that I'm
Acute
wanting you
angle
guys to say.
closure. Acute angle closure glaucoma.
So glaucoma I've already mentioned. There's one more.
Mm,
Is it optic neuritis? I think.
Oh my God, that's genius. I think optic neuritis. Yes,
mhm.
could be. Fine, optic neuritis. One more though. Okay, fine. I'll just tell you guys. Retinal detachment. Okay. So retinal detachment can also cause you to gone, eyesight gone if you're not being okay. Anyway, a patient presents to you with low mood, and she is mom of 1 month old. Very easy. Go ahead, tell me what were we doing?
Urgent referral.
Well done. Okay, but we had to practice your minds. Okay, guys, so this is how every time you're like talking to her, you should have decided, do I need to admit her, do I need to kill her, what do I need to do for her? Okay, let's suppose patient has presented to you with let's suppose increased thirst, and when you did her urine dipstick, you saw ketones positive.
Admit.
And you're in the ER.
Admit.
Sorry. Well done. Admit.
Yes.
Because it's a DKA, she's gonna die if she goes home, honey. It's over for her. But if it's an increased thirst and just glucose increased, that's it. What do you need to do?
Discharge, advice, and labs.
Referral.
Very good. Very good. Referral to a diabetic clinic. Well done.
Mm.
Diabetic clinic, to a endocrinologist, to a specialist, whatever it is. But it's a basically routine referral. And routine referral is the same as doing a discharge. But you tell her, you counsel her that, honey, you have a disease. I'm sorry to tell you that. Okay. So well done, everyone. Brilliant participation. Let's go back to our psychiatry. Let's get sad again. Okay. So did you have any thoughts of the same thing that I just told you? Okay. Now we're done with depression. Never said, let's just read what we wrote over here in the past courses I took. Never say a difficult or awkward thing without signposting. Got it. I told you guys that. If you forget to sign, it's never too late. You can always be like, and have you ever thought of harming? And I'm very sorry to ask about this. Okay. Did you think of it ever? So you get what I'm saying? Even if you have already by mistake said, have you thought of harming yourself? I'm very sorry to ask about this. If you forget, you can totally like do it later. CBT is a talking therapy. Therapists won't don't make sure you don't say that therapist, you can tell the problems to your therapist, he will help you solve them. No. He won't solve your problems for you. He will help you to solve them yourself. But don't say anything about solving problems. Okay? No antidepressants without senior sertraline, sexual reboxetine. We know the 3 antidepressant rule told by Dr. Couye. Well done. 3 suicide. Okay, now let's go to suicide. Okay. Patient presents to you now. Suicide attempts can come to you in psychiatry. And in this also, there is this different structure. So guys, once again, what did I say? Whenever there's an incident, what do? You divide the incident into a before, during, after. So for suicidal attempt, that's exactly what you're going to do. Now listen very carefully. Let's listen very carefully to me, guys. There's only 2 types of suicide cases. Please don't tell anyone I told you that. Usually either suicide will come as a high risk case or a low risk case. So your purpose in the history taking is to make the decision. Is he low risk or is he high risk? That's all. And accordingly, you will give the treatment. Coming to a low risk case. Low risk case will usually be, what are the signs of a low risk suicide case? Signs of low risk suicide case. Number 1, let me tell you, it will be impulsive. For instance, I did not think, I just did it. Who's going to tell me the second? What's a sign of a low risk case? Means she's probably not
Insight.
going to try.
She will,
Sorry, what,
she
Zara?
will have insight
Well
about
done. Insight. She will regret, in other words. Well done, Zara. What else?
They usually seek attention and they're like happy to like be known.
Very good. Okay. So a little bit of an attention seeking attempt. You realize by talking to her that, okay, I get it. She did it because, she wanted this. She had some gain out of it. Very good. That's a very unique point. But otherwise, even if you guys didn't remember, these 2 things will be very impulsive. It will be not basically impulsive, mean it won't be planned at all. It's going to be like all of a sudden. Inside, she will regret about it. Okay. And the third thing is attention. You will notice some gain in that attempt that, okay, maybe she wanted to do it because of this. What are the signs of a high risk suicide case? Just, I think, opposite of whatever we just discussed. Number 1 is it will be well planned. No regret. He's probably going to do it again when he goes home. And the third thing is
suicide note.
suicide note. Very good. So planned is the same thing. He left a suicide note. He logged out of social media. And one more thing would be that he will do it very silently. Like he'll be caught. He'll be caught doing it. He won't like get it. So she had an attention seeking attempt. So she made it known that she did it. Whereas him, he will be like doing it and like his mom's like, oh my God, he did it. He did it. Like someone else will bring this person. She will bring herself, but someone else will bring this person. Okay. So now before, during, after will help us decide who's a low risk case, who's a not low risk case. Okay. So the first question for before is that, okay, Marissa, I understand that you tried to, take some medication. Is that right? Yes, doctor. Is it okay if I can ask you some questions? You have to be very sensitive in this, okay? Is it okay if I can ask you some questions, Ruga? Yes, doctor. By any chance, what exactly happened? If you're having a difficulty asking, did you plan it? Just say what happened before it. What was in your mind before it? Actually, doctor, she'll tell you the whole story. My boyfriend, he broke up with me because I was pregnant, so I just decided to eat all the contraceptives, kill my baby, and then cut my wrists to kill myself. So it's very obvious there's a gain out of this. Gain is to show off to the boyfriend that, bro, yeah, I need attention, love me. You're not loving me enough, okay? And with the person who did it like planned will probably be very low. The person will huge sign, and he probably will be accompanied by the mother. Doctor, he did it. Michael, could you tell me what was in your mind before it? Nothing, doctor. Okay, Michael, did you perhaps leave any kind of a note? So did you notice my volume will mimic the volume of the patient? This is very important IPS, a hack. Okay. So Michael, did you perhaps write any kind of note? Yes, I wrote a note for my mom. Okay, Michael. And were you alone when you did this? Were you waiting for, to get alone at home? Yes, doctor. So that's it. Even ask two questions. You have only 8 minutes. You can't ask too many things. Okay. Next, go to during. Now ask about the incident. For instance, she said, I chugged in some medicines. Okay. It will be written in the prompt that Marissa has come to you. She took some Panadol. She even cut her wrist. Talk to her. Okay. So you'll ask her, could you tell me? Okay. And I'm very sorry to ask you this, but which medicine did you take exactly? Doctor, I took contraceptives. Okay. And how many did you take? I took bunch of them. I don't remember the number. Okay. How did you get access to them? Where did you find them? So these are different questions you can ask related to the attempt. Doctor, I did. And did you take it with water or perhaps you took maybe some alcohol? I'm sorry to ask this. No, no, it was just with water. Okay. For instance, she cut her wrist. What are the during questions of cutting her wrist? Would anybody like to attempt?
Like, where were you? Were you in your room? And then we can ask what was going through your mind, and did you draw the curtains?
Very good. Well done. Wait. Now ask about the incident which is cutting the wrist. Environment. Okay, you asked. Where were you? But talk about the cut a little bit. What can be asked related to the cut?
Like, did you let it bleed? How long did it bleed? Did you stop? Did you try to stop the bleeding?
Very good. So, what I like about Aksa is that her mind is very active. Even if she doesn't know, she's gonna think of something at that. This is what I want, activity. Very good. But even to be more specific, to make it easier for you, you can ask. Okay, I think Raja wanted to say something. Raja, go. I'm cutting my wrist, Raja.
I think first I would ask like, so how did you get the knife? And then I will ask, okay, so what was
How do
going
you know
through
it was
your
a knife?
mind? You said
How
you
do you know it
cut
was a
the
knife?
wrist, cut the wrist. So I'm assuming it'd be a knife. Or okay,
That's
what weapon? What did you use to
this.
fight? Yeah, okay. I guess I can be general, and
But that
then
was
I
good. That was good. That
yeah,
was
and
also good.
then
Good
yeah,
question.
and then I can ask, okay, so where were you when you were doing this? Were you alone? Um, and
Very
what
good.
was going through your mind when you were
Very
making that
good.
first
Very
cut?
good.
Were
Well,
you unsure about it at that point?
very
Or
good.
were you hesitant when you were doing it? Or did you go back again to cut yourself? Like, or did you like she try it another time as well? I think
Okay,
that
good.
is what I'd ask. Yeah.
Very good. Raja has asked brilliant questions. And Raja, I would advise you to keep it to two questions. This is something I'm
Mhm.
teaching you because the more you go into a fourth question, you'll start stumbling upon your words. It's a very natural psychological thing that you might say
Mhm.
something awkward, like the way you just said that. So, did you try to go and cut, like the way you said that? Just ask two maximum questions.
Yeah.
Okay. So,
Okay.
this is a huge hack. The lesser you speak, the you'll say the right things. Okay. Very good.
Mhm.
First thing, what did you use? Guys, Plab 2 is literally what is your general curiosity about this attempt? What exactly did you use to cut yourself? I used a cutter. Where did you get the cutter from? It was in my dad's, stationery room or something. Oh, okay. And how deep was the cut? Or whatever Raja said, like, did you let it bleed? Was it bleeding? How much did it bleed? Anything. Just keep it short, not too many questions because the girl has taken medication and she is cut. So there are two incidents you're exploring. So you should keep the history short. So What did you use and where did you find it? I think these two are important questions. And how deep was it, or whatever bleed you can ask. Okay, now after a simple straightforward question, how did you feel and what happened after it? How did you feel about it? Doctor, I feel awful. She will confess, doctor, I feel awful. That's why I came to the hospital. I ran over here. Doctor, I feel awful. I don't know why I did that. Doctor, I'm very, very regretful about this. And you already know that that's a very good sign that she's regretful about this. So we can send her home. Now, coming to very important in the structure, always remember you need to ask three important questions: the past, the future, and the other ways. Okay. So could you tell me, and I'm very sorry to ask this, Marissa, have you had similar attempts in the past, similar to this? No, doctor. So that's a good sign. And I'm very sorry, if I send you home today, would you perhaps have any similar attempt? Are you planning for it in the future? No, doctor, nothing like that. Never again. And I'm very sorry. Have you ever thought of any other way to maybe harm yourself? Yes, doctor, sometimes I thought of coming under a car, but I was like, no, the car would get ruined. How about a truck? Yeah, trucks don't get ruined. Okay, thank you. So get it? So past, future, and other ways. Now you come to rating her mood. Could you rate your mood for me from 1 to 10? Why are we doing this? The purpose of this is that if her mood is low, we can send her home, but we can also refer her to a CBT so she doesn't have this happening in the future. Okay. And finally, do you have anyone to support you? Is anybody here with you at the moment? Are you alone? Doctor, I'm alone. Okay. Can you tell me about your partner a little bit? This is a safe doctor question. Could you tell me a little bit about your partner? You're saying that you were pregnant with this child. Could you tell me what will you ask about the partner to rule out the safety? Let's see who knows from Plab 1.
Age of the partner.
Very good. Brilliant. Age, because what if she's with someone at a position of authority, maybe her teacher, maybe 10 times older than her? We all know that that's something that's a safeguarding concern. For us, we can't let her go. We have to kill that person over, not kill him, but like take him to the reporting, whatever. So, sorry. Ouch. Okay. So, always remember, we are responsible at NHS. It's a general rule. We are responsible for the vulnerable population. This usually is a teenage girl that comes to us. She's probably 16 years old. Okay, so that's why we are concerned how old her partner is, because she's underage. She's under 18. So our concern is safeguarding concern. Like whenever there's under 18, they're vulnerable group. So we are responsible for them. So honey, no, my partner is a good age. Okay. Okay, thank you. Now let me talk about a low risk case. Let's talk about Marissa, 16, attention seeker, and then we'll talk about Max. Also, he's also like a young guy, 15, and he's a high risk. Okay, how do we deal with Marissa? This is how we deal with her. Okay, so Marissa, thank you so much for opening up with me, and I'm sure it was a very difficult time for you. So Marissa, after assessing you, I believe that you are safe to go home. Okay, but I will also refer you to the talking therapy. Will that be okay with you? Because you're telling me your mood is low. Okay, if her mood was low. Are you following me? Yes, okay. And the purpose over here is that her pregnancy is the issue. So Marissa, I also understand that you're a little overwhelmed about your pregnancy at the moment. How about I refer you to this association? So guys, there's a couple of associations that I want you guys to memorize with me. In NHS, there are a couple of associations that you have to know about, okay? Otherwise, you screw. I'm just kidding. But like, you should know the association, because if you're going to work there, you should know what's available, right? What are the services? So there's a thing called a National Unplanned Pregnancy Association Service, okay? Whenever there's a child who doesn't know what to do about their pregnancy, you just send them there. They are the ones that are going to help them. What do you want to do? If you want to abort, they'll help you abort. If you want to continue the pregnancy, they'll help you decide how to do it and how to provide the support. If you want to go on with the pregnancy or make the baby up for adoption, you can do. Yeah, so that's their job. This is not our job as a doctor. So all you have to tell her is, I will refer you to the National Unplanned Pregnancy Service. How does that sound? Over there, they'll help you decide what to do with the baby, and they will help you with the further planning the pregnancy. Are you following me? Yes, doctor. Okay, and one last thing, guys. What did I say? Always involve your senior in serious cases. So this was a serious case. It was a suicidal attempt. You can't just be like, girl, go home. No. and I will just inform my senior about the situation before you go home. Okay. And Marissa, one more thing. How about call your family to be here with you right now? It's an overwhelming time. How about call a friend, so you're not alone at this time. Okay. And always remember, we are going to be here for you. Okay. We're here for you at any time you have this, come to the hospital immediately. Bye, Marissa. Coming to Max, who's 15. Max literally will say to you, what medication did you take? I took Panadol. Okay. And how did you feel after it? Yeah, doctor, after it, I just felt like nothing. I didn't feel anything. Okay. Do you have any plan to do it in the future? I'm sorry to ask this. Yeah, doctor, I was thinking when I go home, I'll try to do it again. Literally, he says this. I don't know if he actually says it, but in the notes, that's what it says. Yeah, I'm planning to go home and do it. So anyway, in a case whose high risk, simple, simple, simple. Whenever there's a red flag positive, I taught you all, and it's usually going to be ER. Why is it an ER? Obviously, why would a mom whose son had a suicide attempt go to GP? Okay, so obviously she'll take him to the ER. So most likely we're going to admit this patient. So Max, we will have to admit, or if we're talking to the mom, we will have to admit him, because at the moment he does seem like he's at high risk for doing such an attempt again. Are you following me? While he's admitted, we'll have our psychiatry team come to him. We will arrange CBT. If required, we will start him on medication. But this is our plan for now. Are you following me? Yes, doctor. Okay. So this is how you go about. If you're admitting someone, you don't just say, we're admitting you. End of story. Bye. You tell them a little bit about what treatment they will get at the hospital. So it's very obvious. Anyone who's getting admitted is going to be reviewed by the specialist. And obviously, maybe some drugs need to be started because he's very, very, very depressed. And if he's saying very low mood, I'll also refer him to CBT. Okay. So this is how you deal with what do we call suicide cases. Who's going to tell me now, coming for the question Q&A? What? Okay. Who's going to tell me what is the service for unplanned pregnancy? Memorize it with me. That's what I'm trying to do over here.
National
National
Unplanned
Unplanned Pregnancy
Pregnancy
Service.
Association.
Very good, very good. I just wanted to hear you guys say it so that you never forget it, because I'm gonna throw bunch of services at you, and then you will be like, wait, what was the first one again? Okay, what was the seventh one? Okay, because there's gonna be a LCPC, a Healthcare Protection Council. Then there's going to be a Citizen Advisory Bureau, and then there's going to be like a. I literally forgot. There are many, many, many. Okay, so but I will ask you every time. Okay, now let's talk about ADHD. Okay, ADHD. Okay, so whenever a patient presents to you with ADHD, now this guy will come to you like this. This is what he'll be doing. Okay, he will be restless. What will you do? You will acknowledge him. Acknowledge non-verbal cue. So someone open their mic and tell me, what will you say to this kid to acknowledge him?
I can see you're quite anxious.
Okay. Any other word rather than anxious?
Can we say
Jittery.
fidgeting?
Restless.
Yes,
Yes,
yes.
jittery is also a good word. Restless is a very good word. What did Aksa say?
I said fidgety.
Fidgety. Okay, fidgety. You
Not,
seem a bit fidgety. That sounds off. Okay.
yeah,
Try
I
to
thought
be.
so too.
No, that's fine.
Uncomfortable.
Uncomfortable. Yes.
Hyperactive.
Sorry, what? Kuye?
Hyperactive.
Uh, okay. Listen, don't say like, you look like you're not making eye contact with me. You look like you want to like run out of this room. Try to not be very direct, but say a very basic word that will address the whole situation. So basic word, good. You seem a bit restless. You seem a bit agitated. Is everything okay? You seem a bit uneasy, uncomfortable, not bad. But try to address his movement. So movement, I think the best word is restless, agitated. You seem a bit agitated, you seem a bit restless, because jittery is like how do I explain? It's more like a calling him out for what he's doing. Fidgety is also calling him out for what. Hyperactive is also like you are seeming hyperactive. That sounds a little judgmental. So rather just ask him in a way like, I care about you. You seem restless. Is everything okay? You know, trust me, it's a huge difference than like, like telling someone you seem a bit like you look like you have eye bags. Are you okay? Or you say, you seem a bit low. Are you okay? I think obviously the second one is more preferable, right? Because like, honey, what do you mean I will? That's so rude of you. So just like that, don't say hyperactive. Don't say you look fidgety. Okay. So keep your words ready. Keep your neutral words ready at all times. Okay. So keep your, for restless people, always keep agitated, restless, uneasy, uncomfortable. You seem a bit disturbed. Very nice word. Okay. So make up your own script. Yeah, doctor, nothing. Yeah, okay. Could you walk me through what happened? Why are you here today? Very easy case. ADHD is a very easy case. So all you have to do, your structure consists of addressing the AD part, and then it consists of addressing the HD part. Okay. How do you address the AD part? You just ask these three T. You take his T. Okay. What's the T, bro? What's the T? Okay. T for okay, doctor, actually my teacher, she sent me here. She said this, I'm very like I'm not, concentrating in class. Oh, I'm sorry. For instance, his name is Joe. Oh, I'm sorry to hear about that, Joe. Is there any particular reason? Do you think you're not able to concentrate? Yeah, doctor, it's very hard for me to concentrate. So, guys, listen one thing. When someone says that my teacher thinks this is happening to me, my mom thinks that I'm vomiting. First, always ask the person's view on it. Do you think it's true? Okay, is it true? Like, first confirm from him. Is it true? Or is your teacher just mad at you and she sent you here? So is it true? Do you have trouble, focusing in class? Is that it? Yes, doctor. Actually, I've noticed that whenever I try to do my work, it's so difficult for me to, stay focused. Oh, I understand where you're coming from. Must be very difficult. Now you start your ADHD structure. So you say, how long has this been going on for? A quick OD para. From OD, I'll just take the D part of it. How long has this been? Doctor, ever since I was a child. Oh, okay. Would you say you have trouble concentrating? He's already mentioned trouble concentration for a long time. So don't ask this. Would you say you are easily distracted by even tiny bit of distraction? Yes, doctor. And how's your academic performance like? Doctor, it's very bad. It's like depleting and stuff. Oh, I'm very sorry to hear about that. And someone who didn't say, and would you say you have trouble concentrating for a long time? No, yes, doctor, that's the issue. Okay. Now you question him on the hyperactivity part. How do you do that? First things first, non-verbal cue was already there for you. And the second question you're going to ask about is, do you have any trouble remaining seated when you're asked to sit down for a longer time? Yes, doctor, I have huge trouble remaining seated in one place. And would you say you feel restless throughout the day? Yes, doctor. Okay. So there are many, many questions in many, many notes to ask about ADHD, but I always tell you guys to keep it simple. Not more than 3 questions about some important, like if the priority topic, the complaint should have at least 3, 4 questions, but the other things should have one question. Okay. Now coming to DDs. So in a person who's having restlessness, who's unable to concentrate, you quickly rule out a quick autism. Would you say you have trouble maintaining eye contact with others? No, doctor. So his social is fine. And are you able to interact with people? Yes, doctor. And another DD that comes over here is the anxiety. And how about John? How do you feel about your day-to-day tasks? Do you ever feel anxious about completing your work on time? No, doctor, nothing. I hardly have any anxiousness. I'm always very relaxed and I'm just hyperactive. Okay, so always rule out anxiety and autism. All right. And you're telling me that this has been happening since you were a child. So, guys, impact question is that brilliant I for impact, I for IPS question. So don't miss impact question. So it's been going on since you were a child. How have you been coping with this? Oh, it's so difficult, doctor. It's so hard for me to do my homework. It's so hard to do exams. Like life is difficult. I'm very sorry to hear about that, John. I'll be able to help you. Could you just walk me through if you have any medical conditions? Okay, how about any allergies? Anybody in the family with similar issue? No, doctor. Okay, thank you so much for talking to me, John. The only thing you need to do is row your boat. That's what we're going to do in ADHD. The routine referral. This is a case of discharge with a routine referral. Okay. So, Max, it seems like you have a condition called ADHD. It's basically attention deficit hyperactivity disorder. It's a kind of a condition in which you have trouble maintaining concentration and you have periods of where you're feeling very high energy and impulsive. Are you following me? Yes, doctor. So make up your own definition, but it shouldn't be more than one line. Okay, in the meanwhile, because guys, remember, routine referral will take 20 months. So up to 20 months, he'll just be like, oh, I'm ADHD, I'm ADHD. Okay. So in the meanwhile, while you wait for your appointment, how about I refer you to the psychoeducation program? Okay, in the meanwhile, psychoeducation program, there will be some psychologist over there. They'll help you understand this condition. They'll help you cope with it using, various routine hacks or routine tips that they'll give you, advice they'll give you. Okay. And apart from that, I want to give you some general advice on how you can cope with this better is row your boat. Okay. So Mr. Max, just row your boat and see you. Bye. No, never do that. Okay. Go for R. Okay. So Max, whenever you're trying to do work, or your homework, always try to take regular short breaks. Okay, R for regular short breaks. Try to focus at one thing at a time. Okay, try not to have several things on your mind. When you're working, work in a quiet area. And beforehand, when you want to plan a day, write your tasks to plan your day. So you know you can focus on one thing. So these are just the advice you need to give him. Say it in your own words the way you want. But remember, ROW are the advice. Row your boat. Okay, who's going to tell me the ADHD advice now? Disappearing it. Go. Tell the ghost. Tell the ghost with a red flag. What is the he's asking you? Yo. What is the ADHD advice? Kuye, Dr. Kuye, go.
Yeah. So you tell them to have regular short breaks.
Very good.
Yeah, they should focus on one thing at a time.
Very good.
Work in a quiet place and then
Very good.
plan and write down their tasks for the day.
Very good. Even if you forget one or two, it's fine. Just make sure you show the examiner. I know that I need to give him advice also. Okay. I'm a doctor, but doctor also has to give advice, not just medicine. Well done, Dr. Kuye. Well done. Okay, so remember, in the NHS, you are not just a person who gives medicine. I know in our countries we're taught that a doctor is for medicine, okay? But in NHS, it's taught try to keep it without medicine. Tell them a good advice. If required, do the test. Try to treat them without medicine. If required, then add the medicine to it. That's how a good doctor is, not just NHS doctor, okay?
Doctor, how would we define ADHD again? We said that it is. Do we say it is a mental health disorder, or do we say it's a developmental disorder? How would you
Just say it's a condition. That's it. And it's not a
condition?
development, nothing. Yeah, you're just born with. Just say it's a condition in which you have difficulty focusing and you are impulsive. So one word for attention deficit, one word for
Yeah,
hyperactivity. Impulsive is a good word. It's
impulsive. Yeah.
better IPS
Yeah.
word. It's a condition where a person becomes has trouble focusing on task. At the same time, he also is impulsive. So that is a condition. Are you
Mm-hmm.
following me?
Okay.
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 Now coming to the other type of restless guy. Okay, let's talk about the second restless guy that's going to come to you. And it's not going to be an ADHD because he won't be a guy. He won't be a kid. He won't be like a 15, 14-year-old. No, he will be more like an adult. Okay, he's probably like a 25-year-old. Okay, so he'll be sitting and he'll be like fidgeting a lot. Okay, so you're going to ask him, hi, you look uneasy. Okay, because you're bored of saying it all the time, all scripts. I can see you're looking a bit uneasy. Is everything okay, John? Yeah, no, doctor, nothing. Okay. So in the prompt, guys, listen to me very carefully. In the prompt, before you enter the scenario, it will be written, John has been a regular patient at the John has been a regular patient at the GP. He has had two swellings in the past. He has had many tests done. And already outside, before even coming to cubicle, you know that this is a somatoform disease. Okay. So somatoform condition is basically when you think you have all the diseases in the world. Okay. Where you think that what is the difference between health anxiety and somatoform is simple. This is one disease. This is all diseases. Okay. That's the biggest difference that I can tell you. And these people, somatoform people, actually will have symptoms. They will have symptoms and they won't be lying about their symptoms. So, for instance, right now, if I just coughed, guys, I coughed so hard. A somatoform person will be like, I'm coughing. I might have lung cancer. A normal person, like, actually, I coughed, right? It wasn't a lie. So someday he'll be like, doctor, there's a swelling over here. You'll feel there will be a swelling. But we all know it's just a basic lymph nodes because of allergies, right? And then, so that's a somatoform. Now, how will a health anxiety come to you? Health anxiety will be like, doctor, actually, I'm very worried. Why are you worried? He'll also have multiple tests in the past. What are you worried about? Doctor, I am worried about a very random, like one disease, he'll say. Doctor, there's this disease called sickle cell anemia. I think I have it. And I've tried to get tests done before, but I feel like it hasn't been diagnosed before. Now it'll get diagnosed, I'm sure. Doctor, I have it. I have sickle cell anemia. Like he'll be obsessed about a random AF disease, no offense to him. So he'll just have this Google term ready. So where the somatoform person is like, doctor, I think I have lung cancer. Doctor, I also have a swelling. Maybe it's because of skin cancer. Okay, doctor, I also have some bowel difficulties. Doctor, do you think I have inflammatory bowel disease? Okay, and also, doctor, yeah, I just want to tell you, I have this headache. Sometimes I feel like, what if it's, that acoustic neuroma situation going on? Hey, how do you know acoustic neuroma? You're just a patient. You're not a doctor. Oh, shoot, I completely forgot. I was supposed to act. Sorry. Okay, so this, and the third variant of anxiety cases is a medical intern syndrome. This is a new case that has been added recently. And in this case, you will have Raja sitting in front of you, Aksa sitting in front of you, a medical student will be sitting in front of you. When you'll ask them, hi, how are you doing? It's most likely going to be a medical student has come to you to talk to you. Either they won't say medical student, but when you ask, so what do you do? Doctor, I'm studying for medical school. This is why. So medical interns issue will also be doctor, I just started my third year rotation and we have started to go into wards now. This will happen. Medical intern syndrome will happen when they just started their rotations. First time they entered the hospital and they saw so many different types of diseases that they got overwhelmed. That, oh my God, people die of diseases. This is mixed with, what if I have a disease? So they go into this whole world of like this whole pool, what do you call it? Like a whole roller coaster of emotions, right? So that's medical intern syndrome. You should know basics. Basics is to differentiate the three from each other. Health anxiety stuck on one disease. Doctor, my brother had sickle cell anemia. I have it. Not brother, cousin. I have it. I have it. Doctor, sickle cell anemia, sickle cell anemia, some random AF disease. Doctor, I think I have Cartegner syndrome. Doctor, Cartegner. Coming to somatoform. Somatoform, doctor, it could be cancer. Doctor, also have a swelling over here. Doctor, do you think it's thyroid disease? Oh, doctor, I couldn't see from my eyes. Doctor, sometimes I feel like I have glaucoma. Typical somatoform disease. And you literally see people around you that have somatoform. I'm sure you know one or two people around in your life that had a somatoform. Now you know how to word it. And finally, medical intern will always, when you talk to them, when you take their history, they'll be like, doctor, I just entered my third year medical college. Okay. So how will you take their history? Very simple. Same thing, basic structure is, explore complaint. Doctor, I have swelling. Okay. Could you tell me OD para of swelling? How long it's been going on? Is red flag, who's going to tell me the red flag question for swelling?
Did the swelling happen recently?
How is that a
Is
red flag?
there, I know, some trauma maybe?
No, red flag means how can someone die of a swelling? So what are the symptoms I need?
Okay.
If it's changing, is
By
the
asking
character
about
like it's
weight loss,
glowing or color?
That's it. Zara has to say something. Zara, go ahead.
no, I thought by asking the questions like weight loss and stuff.
Yeah, you can ask the systemic questions, but the swelling based question you should ask, did you see it growing in size? Progression, very important. If a swelling is growing, then I have to believe him. I have to be worried. And what is the management I'll do in a person who says my swelling has been growing?
2-week urgent pathway.
Well done. Brilliant. Okay. 2-week pathway referral. Okay. So that's why I need to assess. Wait, is your swelling growing? Swelling growing. So why does that sound wrong? Does your swelling grow? Has it gotten bigger since the last time you saw it? No, no, no. Or yes, doctor. Then you have to be like, did you notice any weight loss, lumps and bumps, fever, anorexia, or night sweats? He'll be like, what the hell, doctor? Okay. So anyway, So moving on. So anyway, where were we? Yeah. So is the swelling growing? No, doctor, it's not growing. Okay. And how about your weight? How's it? Any fluctuation in weight? No, doctor. How about any night sweat? No, doctor. All right. Can you also tell me, notice any other lumps apart from this? No, doctor. Nothing. Okay. And I also understand from my notes that you previously also got some tests done. What was the reason for it? Doctor, I last time actually I was having this headache, so I was kind of concerned, because I read somewhere that brain cancer usually begins with a headache. You already have diagnosed this guy with a somatoform. Okay, all right. And right now, how's your headache? Oh, doctor, it's gone. Okay. And also, could you tell me, even before that, I can see you had another swelling. Yeah, doctor, actually, it was like a dark brown lump, and someone said it could be a melanoma. So that's why. So basically, in the history taking, okay, okay, no problem. See you. I'll be waiting for you. Okay. No, doctor. No students. I wasn't talking to a ghost. Someone directly messaged me that they are going to be right back. Okay. Now, where were we? I was saying that this is ADHD, by the way. I think I have monospectrum because I forget. I lose my train of thought like that in simple distraction. What was I talking? Yeah. So the history of an anxiety somatoform, all of these is just talking to him about, okay, what happened previously? At that time, what did you do for it? Did you have any red flags at that time? Okay, how are you now? So you're just taking basic history and then you go for, after exploring complaint, you go for DDs. What are the DDs? Over here, you'll ask him. Okay, so I can see you're quite restless. Have you ever had any problems with attention? He'll say no. Okay, ADHD. You have to show to the examiner, hi, I ruled out ADHD. Okay. And apart from that, is there anything else? Have you talked? Now you just go for the famish history. Famish, do you have anyone? Do you talk to anyone about it? Have you ever discussed this with anyone? No, doctor. Anybody in the family with similar situation that, they might be like anxious? No, doctor. And do you think your day-to-day tasks are difficult for you to do because you're anxious most of the time? Yes, doctor. So these are the things you need to basically talk about. When it comes to medical intern syndrome, these are the questions you need to ask. Too many symptoms started when rotation. They'll be like, doctor, I've been feeling very like, I'm having a headache. And doctor also, yeah, I wanted to tell you there's this, I feel like a burning in my chest. Okay. And what do you do for a living? Basically, doctor, I'm a medical student. And I just started my third year. Oh, okay. How are you going to structure this? You're going to ask their fears. Okay. Could you tell me if it's okay if I can ask you, what are your fears? Like what is there anything you're in particularly worried about? Yeah, doctor, sometimes I feel like, what if I die the way my patients die? So basically, medical intern syndrome is something that when someone newly comes into wards, they get a little overwhelmed and they think that, there's too much going on. And then they think maybe I'm sick too because all of these diseases can happen in people. Then why can't it happen to me? You get what I'm saying? You ask their fears, then you ask their famish history. Anybody in the family the same? F for like, did you talk about it with your friends? How are your exams going? When are your exams? Are you prepared for it? Are you feeling more anxious? And so that's completely up to you what you want to create the structure to be. Just make sure you're doing the red flags and you're exploring the complaint. Okay. Now, how do you manage? Always, all three you manage by telling them that, bro, you are okay. You are normal. Calm down. I love you. I love. So what did I say in Plab 2? Fake it till you make it and exaggerate your emotions. I love you. No, don't actually say that. This is mostly my advice for introverts because I have to make them exaggerate for them to even baseline bring in expression. Okay. So first things first is that what you're telling me, it seems like you are completely okay, Marissa. There's nothing going on. I've asked you, from what I gather, there's nothing that sounds any sinister over here. It doesn't seem like you even need anything done. Okay. But just for your satisfaction, we will do some routine tests. How does that sound? Okay, doctor. We'll run tests, and once you see the test that hopefully they're going to be normal. Once they're normal, then you'll know that nothing's going on. How does that sound? Yes. And for all of them, there's just one treatment, CBT. Okay. And I will also refer you for a talking therapy. Sometimes there's so many thoughts going on in a person's mind. To organize them is usually the solution. And for that, I will refer you to a CBT to be seen by a therapist or a psychologist. These two. So CBT is basically a form of talking therapy where a psychologist or a therapist, one of the two, basically helps you with it. Okay. And apart from that, see, Max, I can see you're very restless. You're seeming, no, don't say it. That's rude. Max, I can see you're seeming a bit agitated. So I do advise that you practice some, stress relief exercise. Try to, maybe enroll yourself in some yoga classes, or maybe just use YouTube and, see relaxation exercises and meditate on a daily basis. Okay. And make sure your diet is good. Stay relaxed. And I assure you, nothing is going on, Max. Okay, because this is starting to affect your day-to-day life. Just want you to know that relax, everything's okay. Okay, so just be very nice to them and be like, I love you, like, kill me if you want, you can kill me to feel better. Yeah, I'll kill myself for you. Like, that's how much you need to exaggerate the niceness. Okay, so this is for medical intern syndrome. This is what you do. For somatoform, same thing. He's already done 20 tests. In this somatoform, you don't tell him to do more tests. You say, see, even the tests previously came back normal. So there is no benefit that I draw your blood again and make those tests happen again. I have examined your swelling. This is completely normal. It's a benign lymph node. But at the moment, I'm more concerned because, John, I feel like you're having a condition called somatoform. It's people when they're worried about having different type of diseases. So it's a whole condition in itself. The reason I'm worried is that it's affecting your day-to-day life. Like, you're having difficulty doing your day-to-day work. That's how much it's. So how about a talking therapy? And also, I advise write down in a diary why you think you have the disease and the factors that work opposite to it. Like, why you don't have the disease. Weigh out the two things, and that will also help you a lot. Okay. So these are just some basic things. You can make up your own things to advise. Okay. So up to now, guys, we've come from depression to suicide. That was such a rude thing to do. We've depressed ourselves, then we went to suicide, then we did the ADHD, we did all anxieties. Okay. So what do we have left? We have the golden case of Plab 2 coming up. But for this case, I want us all to have some, what do you call it? We need to rewind. No, wait. We need to refresh ourselves first, right? So this is a schizophrenic, and this case comes till date in the exam, and majority fail this case. What is so special about this case? We need to find out how to address this case. And this is my favorite because I tell you guys the most common mistakes and I fix them and I make it easy for you to address a schizophrenic. Guys, it's very difficult to deal with schizophrenic because you don't know how to talk to him, because he's saying to you that people after him, he's doing weird things, and you're just like, I'm a little uncomfortable right now. Especially introverts will have difficulty with this case. Okay, so we're going to deal with psychosis when we're back from the break. So we'll do psychosis, which is basically schizophrenia. Bulimia, anorexia, we might do in another class because that's also very important psychiatry, like a whole thing. Then we have the heroin and alcohol abuse. And then we have the memory situation.
Dr.
Yeah.
Husna, I just had a quick question. So in somatoform, do we actually verbalize that, okay, if that's okay, I'll examine your swelling. And then they say, okay, the findings are normal. Then we say somatoform.
See, findings are normal. So obviously it's somatoform.
Okay, okay. So we do say that, okay, we will examine the swelling.
Yeah, you have to verbalize. I would like to have a look at your swelling. He will give you a clipboard. Clipboard will show normal swelling. It's mobile, and it's like the most benign signs, like soft swelling, benign, and stuck to the skin. Every benign thing will be written, okay?
Okay, 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 thank you.
But even if they don't give you a clipboard, by his history, it will be very obvious that he has somatoform because he'll be fidgety. He'll be like that, okay?
Okay.
So well done, guys. For up to now, if you've listened, you've come very far in psychiatry. Nobody can take this honor from you. What you've learned today is just next level. Okay. So I want the same amount of participation when we go back to schizophrenia. Let's take a, how long should we take the break? Let's take a 10-minute break. Maybe eat, get some lunch in, and then we go for the difficult, like scary cases coming through. Okay. Psychosis and anorexia, two very extremely important parts of Plab 2. See you all in 15 minutes. Let's take 15 minutes. Okay, I'm going to write it down. 15 minutes. See you all. But have like same amount of focus and participation. Yes, we are back from the break. You guys are probably, where did she go? I was eating some lunch. So, yeah, lunch was fun. Takes some time to eat, because I have to, if I don't eat good, then how will I be able to teach good, right? So, yeah, if I'm taking the time, then it's for some use. So, we are starting. Let's see if everyone's in. Aksa's in. That's it. I just need Aksa to be in, and I'm just starting because I. Okay. Zara's like, bro. What about me? What about me? And Summer's like, bro, see, I have a kid, but I'm still gonna be here. Okay. Well done, guys. Well done. So proud of your activity, your energy. That's all I need. That's all I need. Energy, so that I know that if I'm working so hard, there's some people that are actually listening and having the result of it. So my mind slows down after eating food. So yeah, let's just watch that happen with me, okay? Okay. So okay, can someone just message in the registered members group that we are back from the break so nobody gets mad at me? Because I don't even have my phone, but I don't know where my phone is. So let's start with the schizophrenia. Okay. So now the patient comes to you, psychosis. What is the difference between psychosis and schizophrenia? What's the difference between psychosis and schizophrenia? Who's going to tell me? I want to see your concepts. I'm checking the concepts.
Psychosis is a part of schizophrenia.
Very good. What is the definition of psychosis?
In which
So
people
the
experience things or hear voices which in actual sense it not be true. It's a
very good.
condition of all that.
Very good, Summer. Okay. See, you can see Summer's hard work coming into play. Oh my God, my brain's not working. Okay. Well done. So psychosis is every time someone hallucinates, not just hallucinates, but everything that comes in someone going psycho. That's so rude of me, right? So what comes under that category? One of them is hallucination, as she rightly said. Number two is delusion. You become deluded. That's also a part of psychosis. All of these things, psychosis is every time you're losing touch with reality, you are becoming a psychosis. Okay, that's so rude of me. When people tend to lose touch with reality, that's when we call it psychosis. So it can be in many ways. It can be in a way that they're hallucinating and losing touch with it. They can be deluded. What is the meaning of delusion? Let's check your concept. Concept check.
When you have a firm belief in something that's not true.
Very good. So proud of you. Well done, Aksa. So if I start saying that, guys, listen to me, I am taking the Plab 2. I'm not the one that's giving it. I am NHS. I am the NHS. This is a belief that I hold. I am the NHS. This is a psychosis. What form of psychosis is this? This is a delusion. Very good. And then do you guys hear that? Someone saying that Dr. Hasna is the best. Yeah, that's called hallucinating. What do you call it? Auditory hallucination. Okay, all of these things. Someone, guys, listen to me. I think you guys are taking thoughts. You guys are stealing my thoughts. You guys are stealing my thoughts. You guys are stealing. I don't want to. This is what is this? This is a thought disorder. This also comes under psychosis. Anything that makes you to like you're saying odd things, you're saying bizarre things. This is all coming under that umbrella of psychosis. Okay, now coming to what is schizophrenia. Schizophrenia as a whole, you need a criteria. Okay, just like Zara said, very good. It's psychosis is a part of schizophrenia, but you need a criteria. For instance, psychosis should be present for 6 months with negative symptoms as well. Okay, what are negative symptoms? Depression, low, lack of movement. All of these are negative symptoms. Okay, and positive symptoms are hallucination. Yes, Hi, how are you? Even mania comes under psychosis. Anything that's making you lose your mind is psychosis. And schizophrenia as diagnosis, you need a criteria to be fulfilled. What is the criteria? That you need to be having symptoms for more than 6 months. There should be the combination of a psychosis or the positive symptoms and the negative symptoms as well. Only then you can label it as schizophrenia. Okay, so the schizophrenia has a proper like a criteria to diagnose. The question here is for us guys, FY2s, future FY2s, the only question or the only responsibility you have is to know, can I make a diagnosis of schizophrenia or not? No. In a GP, you cannot make the schizophrenia, but you can definitely make a diagnosis of psychosis. And you will be worried that it might be, you might have psychosis because of schizophrenia. We never know. For that, you need to be assessed. That's my duty to do as a junior doctor. Okay, so you should also know as a GP, how many things can you diagnose? What can you diagnose? You can, let's see if you guys know, okay? Because this is challenging. So as a GP, can you diagnose someone with cancer?
Not really. We can
Very good.
suspect.
That's fine. Exactly. We can only suspect it. Can we diagnose anorexia?
Yeah,
Well done. Why?
because it's like basically history and like bedside like BMI based.
So basically, it's a clinical diagnosis. There is no special test for it. For a cancer, we need a biopsy. That's the confirmatory test. For ADHD, for somatoform, for anorexia, all of these are clinical diagnoses. We can easily do them. Let's talk about schizophrenia. Schizophrenia, remember one thing. There is no way we can diagnose schizophrenia. Only a psychiatrist, he knows the specific questionnaire that he uses to diagnose, to label someone as schizophrenic. Depression, we can diagnose. That's why we can even treat him. Okay. Let's say, are you able to diagnose someone with scleritis?
Yeah.
Yes.
Very good. Okay, so you can say that I am suspecting scleritis. You have to go to the okay. Every time you have to, however, you have to say suspecting. Okay, but can you diagnose something called diabetes? Yes. Anything that's clinically obvious, like bedside test shows high glucose in the urine, I think I can safely say it's diabetes. At least we can safely say it's diabetes. And even depression, anorexia, all of these are clinical diagnoses. This we can 100% do on our own. We don't need anyone. Okay. Now let's talk about wow, what did I do? So anyway, So anyway, let's talk about psychosis. So whenever a patient comes to you, let me tell you how the case will come. Okay, and it's been coming these days. It's been coming for years and years, and there is no crack to this scenario. Okay, but we can try. I'm just kidding. With me, there's no trying. There's only topping. You will only top. Okay. So psychosis will present as Will is a patient who has come to you whose father has booked him with an appointment. So this is usually a video call case. Okay, and it's always the patient will never be booking the call, which is very obvious. It shows that he does not have any insight. If someone comes to you themselves, it's an insight. If they're not coming to themselves, someone else booked it for them, it's most likely he has zero insight. So that's already a red flag in its own. Okay, so what I forgot, what was my point with all of this? My point with all of this is, yeah, that's why I haven't written, if you guys notice, I haven't written schizophrenia here because we can make it, but we definitely know this guy is psychosed. Okay, let's start. What's his name again? I think his name was Michael Jones, right? So Michael Jones, the father of Michael Jones has booked an appointment, a video call appointment with you because the father says that Michael has been acting, behaving oddly in the past couple of days. So now you know you have no idea in the exam. Right now, you know we're discussing psychiatry, so you know we're talking about schedule. But in the exam, you'll be like, you'll never know what the case is. You'll just read a basic prompt and it could be anything. There's so many cases that come like that. Okay. So what you're gonna do is first things first, you're gonna enter the room and you're gonna say, all right, hello, Michael, I'm this. Okay, I can see that your father has booked an appointment. Could you walk me through what happened? Why does he think you need an appointment? He'll say, I don't know, ask my dad. So he has no insight. He hates his dad right now. Okay. doctor, like, or whatever his approach is, you have to do one thing, write it down. Okay, the hack is befriend him. Forget father. Befriend him. Forget father. Okay. So you know what people start to do? They're like, see, your father cares for you. Your father cares for you. That's why he booked an appointment for you. Fine. I get that. That's a good thing to say. But if you want him to spill the beans, then you have to become his friend rather than looking like, I'm with your father. I'm also the police. I'm also here to kidnap you. Tell me, why does he think you're killing people? So you need to make him confide in you. Okay. So what you'll say, all right. So I'm sure your father cares about you. That's why, yeah, whatever, doctor. Okay. Anyway, Johns, let's just have a general chat. How does that sound? So you're going to have a general chat with this guy. So this is where everyone struggles the most with schizophrenia, is how to get it out of him that he is having schizophrenia, because obviously he has no insight. He thinks he's seeing the people. He thinks they're real. Why would he say this is a problem? Like he won't tell the doctor, right, that people are after me. He'll probably tell the police, yes, there are people after me, but why would he tell the doctor police are after me? He doesn't think he has a disease. He thinks he's actually seeing those people. So this is where the psyche comes in, right? So what you're going to do is have a general chat with him, and then you just watch him spill the beans. Okay, just say, okay, how about we have a general chat? How does that sound, Michael? Okay, so Michael, tell me, how's your day-to-day activities going? How's everything going? So he might just tell you, he'll be like, I haven't been eating that well. Otherwise, everything's fine. Okay. Oh, you just have to somehow get it out of it, right? So, why, Michael? Why do you say you haven't been eating? Nothing, doctor. I'm just worried. Oh, okay. What is it that you're worried about? Nothing, doctor. Just imagine someone's just staring at you right now from outside the window. Why don't you think I'll stop eating? And then you'll be like, oh, that's when you'll begin your structure. You get what I'm saying? So just making him open up is the tricky part. So you can always have your general chat ready. How to have your general chat ready? Let me teach you. General chat questions, the things that you can ask to keep yourself, make him open up. How's life going? How's day-to-day activities going? Okay? So daily activities you can ask. The second thing you can do is you can ask him, so what do you do for a living, Michael? How's everything going? What do you do for a living is a good question, because you know what he'll tell you? He'll tell you, oh, actually, no, doctor, I lost my job a month ago. And that's where you'll know, okay, how have you been coping with that? Is there any particular reason why you lost your job? Somewhere over there is your answer, is you making him open up. So that's it. It's all the beautiful technique of making him open up. Okay. So it's all the beautiful way you make him open up. It's going to be as quick as you can make him open up. It'll be good for you. Okay. Now come to the next part of the structure is, oh, doctor, I'm seeing people outside my room. So the first things first is become deluded with him. But, okay, here's a deal. I need to tell you guys this, okay? Honey, don't stick to an extreme side, okay? What I mean is, don't believe it completely and don't completely disregard it. Stay in the middle. Okay, because I've seen some students, they make this mistake where they start saying, oh my God, please tell me about those people. I'm so curious about them. Oh, you're a spy. That's so good to hear. So don't choose extreme things. Stay neutral. Just very extremely neutral. Don't say yes to him. Don't say no, this is wrong to him. Nothing. Neutral. As a doctor, you can't lie. Okay. You have to be very neutral. Okay. So could you tell me, okay, you told me someone's staring at you, so be very careful. Your active listening is going to come to play. You told me that someone's staring at you from outside the window. Is that right, John? Yes, doctor. So who is it, John? So you need to at least ask 3 questions related to that and become deluded with him. All you need to do with this part is to get an idea of, you just need to get it out of him that he's seeing things that are not there. Okay. Oh, doctor, sorry. John, who is this person staring at you? Doctor, don't ask. It's just these people, they're after my life. Oh, I'm so sorry. That must have been so difficult for you to deal with. Who are these people, John? Doctor, they're actually, I'm the son of King Charles, and they're out to get me because I have a lot of property with me. Oh, okay. That sounds a little distressing. So I did not say yes or no. I left a very neutral remark. That sounds distressing. That's not a lie. That's not a lie. Am I lying? No, I'm not lying. That does sound distressing if you're seeing those things, you know. So you can't just be like, you're the father of King Charles. Wow, that's nice to know. No, no, don't do that. Okay, some people believe in doing that. Oh, wow, you're the father of King Charles. Like, don't like get deluded to the extent that you're believing what they're saying. That's not fine. That's actually you lying to them. Okay. Now, so can you tell me what is it that why are they after you, doctor? Because they want my property. Okay. Now you smoothly go into your red flag question. You're gonna ask him, so, would you say you're feeling unsafe, John? Because you know they're after you. Yes, doctor, I'm feeling very unsafe. Oh, and I'm sorry to ask this, John, because you're feeling unsafe. Do you carry anything with you to feel better? Yes, doctor, I have a weapon. And there you have it. That right there, guys, is your reason to take him to the hospital. Now you know red flag is positive. That's all you needed to get out from him. Once that's out, now you have a reasonable argument, you justification why you're going to admit this patient. Okay. Okay, John. Um, what weapon are you carrying? Doctor, it's a knife. Okay. So I'm not saying, oh my God, that's so bad. Or I'm not saying, it's valid. Don't say that. Okay. Now let's talk about impact and DDs. So you're saying this has been going on. Don't ever slip tongue. Don't slip your tongue by saying you're telling me you're seeing people. Shh. No, you can't do that because you just literally just told him, I don't believe you. Okay, so don't do that. It's a slip of tongue. So you're telling me you're seeing people. No, be very careful. So you're telling me these people are after you for a month now. Could you tell? And you didn't lie. That's what he told you, right? So could you tell me how this has been impacting your day-to-day life? You told me you couldn't eat. How about how's your sleep been? And how is everything else going? Doctor, I'm unable to do this, that. Okay. Quickly take a quick physical health assessment. Why? Because sometimes when someone is going through an infection, the fever may cause delirium and person can become deluded because of that. Could you tell me if you recently had any kind of physical illness, any flu? How about right now? Any urinary issues? Have you had any headache, any cough? No? Okay, that's good to hear. That's good. And apart, now you'll assess about his other psychosis. So, what are the other psychosis? Thought disorders, auditory. So, don't again ask, are you seeing things that other people are? Some people, I promise, some people actually do it. Some people literally say it. They're like, so tell me, do you tend to see things that are not there? Okay, like obviously he just told you he's seeing things that are not there. And obviously when you say, are you seeing things that are not there? He's going to be like, no, I don't see anything that's not there, obviously. So what you need to assess is, are there auditory hallucination involved? How to assess that? Would anybody like to try? I don't like to be the one speaking for too long. I need to change that up. How can you ask about auditory hallucination? You can't just be like,
Do
do you hear
you
things that are
by
not there?
let me
Yeah,
okay.
yeah.
Do you by chance hear somebody or hear some voices that other people around you may not be hearing?
See, this is not the right question just because you're telling him that people around you cannot hear. So it seems like he's crazy. You don't want to make him believe that, right? So
You
all you
also
need,
let him, you say something like, okay, well, people in your that have people of your age or people
yeah, I get it.
who normally experience this may have something like hearing voices around them on your own. Do you by chance also hear this?
Very good. So Kuya, this is a good question. When people have insight, that's when you can ask the questions. You already know that this patient does not have any insight that this is wrong. So in a patient like this, it is a tricky question that I asked. So in a patient like this, you know how to assess the auditory hallucination? All you need to say is, are those people saying anything to you? That's it. We all know those people are not real. We all know King Charles is not real. Do those people talk to you by any chance? Do they say anything to you? That's a very tricky way to ask someone without an insight. Okay. Okay. Has it ever happened, John, that you felt like, your thoughts are being stolen? No, doctor, nothing like that. Okay. Thoughts done. Insight, we don't need to ask this question. I don't even know why I've written it, but I think that there's no need to ask. It's very obvious he has no insight. And then support. So, John, I can see that this is a very difficult situation that you're in. You're worried about yourself, you're feeling unsafe. Have you talked about this with anyone, like to feel better, like maybe to your family or anyone? No, doctor, I tried talking to my father yesterday and he started calling me crazy. I completely understand. Like, this is something that maybe not everyone might understand. Okay, John, thank you for talking to me. Now, listen, keep the history not too long because this part might take a little time. Okay. So, okay. Ready? So now this is how you address a schizophrenic. And I want all of you to practice with me today. Okay, how do you address a schizophrenic? Do you just tell them that, bro, you're sick? Or do you just trick them like, come to my hospital and then I'll keep you safe from King Charles? Okay, let's find out. This is exactly how you're going to address it. Okay. Thank you for opening up with me, John. Okay. I highly appreciate. I know these things are very difficult to talk about. John, I need to tell you this, but um, sometimes, when people are going through difficult times and, difficult situations, they tend to see things that are not there. Okay. The things you are telling me, John, I don't say that you're lying to me, but they just sound a bit out of reality. And I'm not saying that you are lying. Okay. Sometimes because people are going through a difficult time, their brain chemicals get disturbed, which makes them see these things. Okay. So, John, for that, I advise that, you come to the hospital immediately. No, doctor, he'll instantly disagree with you. Okay. Sorry. I think I kind of forgot the structure. Wait, let me just say it again one more time. Okay. Take two. John, so everything you are telling me sounds a bit out of reality. You're telling me that there are people coming after you. Yes, I'm sure. I know that you're not lying. But the truth is, when some people are going through difficult time, as you told me, you lost your job a month ago. Sometimes the brain chemicals get disturbed and you start seeing things that are not there. This is something we call as psychosis. Are you following me, John? Whatever, doctor. See, John, I'm worried for you because psychosis could be an early symptom of something called schizophrenia. And I just need to make sure that everything is okay with you and you are taken care of. So, John, how about come to the hospital? He'll say, no, doctor, I don't think I'm sick. No, okay, fine. John, see, whether you're sick or not, if you come to the hospital, you're going to feel 10 times more safer than you're feeling at home. Nothing can happen to you in the hospital. There's going to be a whole team. There's going to be psychiatrists. There's going to be medicine specialists. You're going to feel safe. And at the same time, they will even do your tests if required to see everything is okay with you. They'll give you some medication, and that medication will make you feel 10 times better. How does that sound, John? Doctor, I can't come to the hospital. Okay, so in this case, he will never come to the hospital. Is there any particular reason why you're so worried about coming to the hospital? Doctor, if I leave my house, they will attack me and I'll die. Oh, I'm very sorry to hear about that, John. Okay, John, let's do this. How about we send a team to you? Okay, this is the Crisis Resolution Home Treatment Team. New term. Memorize it. Crisis Resolution Home Treatment Team. This is for all those cases that they just want to stay safe, because these type of patients, they usually feel safer in their familiar surroundings. So UV, especially NHS, has made this team for those people. This team goes to their home and provides the same care that they'll get in the hospital. So how about we send a team to you? And this team will consist of same psychiatrists, specialists that are going to look after you. How does that sound? So he will never agree to the hospital admission, but eventually he says okay to the crisis resolution home treatment team. But make sure it takes you, like, try to convince him first and then go to the CRHTT. Okay? Okay, fine. We'll send a team and they'll look after you. You're going to feel safer with them around. And trust me, John, we're here for you. At any time you want to talk about anything, we're here. At any time you feel the need to use your knife for anything, please, here's a number and I want you to call on this number immediately. Are you following me, John? John, you're not alone. I can see that you're quite worn out by this. You are not alone. Trust us, we are here for you. Okay, we're just a call away. So you have to be extremely nice to them. Okay, so how do you go about this case? The structure is number one, things are bit out of reality, what you're telling me. Number two, please tell him, you're not lying. I know you're not lying. But when people are going through difficult times, sometimes like you lost your job, they see things that are not there. This is called psychosis. Fourth thing, this might be an early sign of schizophrenia. So for that, come to the hospital. How does that sound? He'll say no. Is there any particular reason? Because this. Okay. How about we send a crisis resolution team to you? Okay, done. Would you like to know what they'll do for you? There's going to be psychiatrists, there's going to be this, therapists, they're all going to be looking after you. If required, they'll give you medicines. Okay. Called antipsychotics. If you want to say it, you can say it. If you don't, it's okay. Are you following me? Okay. Very important. Support him. We are here for you. John, listen, you are very worn out by this. I can see you. But remember, we are here for you at any time, and we're call away. Anytime you safety net. Anytime you feel like things are getting out of control, call us. We will instantly be there. Okay. So, would anybody like to try the management of this case? Because this is very tricky management.
Yeah.
Okay, go that. So I am Michael, and tell me that whatever I told you, 1, 2, 3, 4, 5, 6, 7, 8, 8 points.
Okay.
Start.
Thank you. Thank you, Michael, for opening up with me. Michael, I understand that it's very difficult to share these things with anyone. But look, Michael, I understand that you are not lying. But Michael, this is a bit out of reality. This might be early signs of schizophrenia.
First tell him psychosis, then go to schizophrenia.
Okay. So, Michael, sometimes you tend to see things due to irregularity in the hormones released in the brain.
Okay.
This condition is called schizophrenia. This
No.
condition is called psychosis.
And it may be a
I
sign.
fear that this might be an early sign of schizophrenia. So
Ask him, are you following me? Keep asking, are you following me after every point?
Are you following me, Michael?
Whatever. So he's never gonna say yes, obviously. Next.
Okay, so we need to admit you to the hospital, Michael.
Okay,
Are
admit
you
might be a
following?
very strong term. Admit
Okay.
is a little stronger term. Just say, how about can you come to the hospital right now? That's it. And then admission, we can talk to it later, okay?
Okay,
So?
Michael, can you please come to the hospital right now?
No, doctor.
As it is. Okay, I understand, Michael. Let's take it this way. So, can you tell me why do you not want to come to hospital?
Doctor, why should I come to the hospital? I'm not sick.
I understand, Michael, but you need
So in a
help.
case like this, always tell him what is going to benefit him, right? So for him, he wants safety. So use that. So
Yeah.
see, in the hospital, you can come, you're gonna feel safe. You go.
Yeah. So, Michael, it's you'll feel safe in the hospital. If you come to the hospital, there will be a lot of safety for you. There will be a whole medical team to assist you. You won't be alone, Michael.
I can't leave my house. They're gonna kill me.
Okay. There's another solution for you. We can send a crisis resolution home treatment team at your home, which includes all the multidisciplinary team that would help you get treated. This way, you won't feel unsafe. Is that fine?
Okay.
Okay. Is it okay?
Are you going to support me? There's a support at the end, support, and then safety net. So obviously,
Okay.
and you have to always imagine that this is your friend. So obviously, you won't just be like, hey, listen, go to the medical, go to the hospital, go get some help. Bye. You'll obviously be like, I'm here for you, my love. Oh my God, I'll kill myself. Just you don't kill yourself, please. Okay? So go. Support me.
Michael, you don't need to worry. I'm here for you. I give you this number. You can call at it any time you feel unsafe or you feel any problem.
Very good.
Okay. Is that
Very
okay?
well done. So, well done, Zara, for attempting this because it's not easy. This is a very difficult scenario. Even just look at this. You guys probably noticed this is the first scenario that it's a little difficult. It is a difficult scenario, and not everyone passes this exam. Sorry, scenario. So, because it's difficult. Did I just say the same thing 3 times? Yeah, my brain not braining. Okay. So anyway, a little bit, I want to tell you one tiny piece of advice. Never say, I am here for you. Never say, I will help you. Always keep it to we. So it's like a medical team. Okay. So yeah, I don't, I, no, I'm not into you. I don't like you like that. It's just that we are here for you. Yeah, that's what I meant, right? You get what I'm saying? So try to say we rather than I. Okay. And apart from this, does anybody else want to try this entire scenario? I'll do it one more time for you guys. Okay, who would like to try? Did anybody decide? I'll do it one more time for you and then copy it again. Okay. Thank you for talking to me. Thank you for opening up with me, Michael. See, you know what you're telling me. And look at my tone also. Look at my tone. I'm not, thank you for talking to me, Michael. And from whatever you're telling me, it seems like you are having, what, bro, 1 second. Why are you teaching me what's going on? Like, what the hell? Okay, you're a teacher in UkpassAcademy, not in my consultation. So anyway, always remember match the tone. It's a little bit of a sensitive scenario. So, okay. So, Michael, everything you've told me, the people after you, and they're probably out to get you because of your property. You can totally summarize it. Okay, so, Michael, see, the things that you are telling me, they're a bit out of reality. And I'm not saying you're lying, not at all. I know, I'm sure that you're seeing this. But see, when sometimes people are going through difficult times in their life, like you told me you lost your job, the brain chemicals get a little bit irregular and people tend to see things and hear things that are not there. So this is something, Michael, we call as psychosis. Are you following me, Michael? And it might be an early sign that it could be of schizophrenia. However, to be able to say anything, Michael, I advise that you come to the hospital. How does that sound? See, in the hospital, there's going to be a team, there's going to be a psychiatrist, they're going to assess you. They're going to see if any test is required for you. Maybe you have some physical health, anything. And then they'll start you on medication. These are called antipsychotics. You're going to feel instantly better. How does that sound, Michael? Just come. No? Okay. See, Michael, the most important thing that when you come to the hospital, you're going to be super safe. You're going to feel a lot safe here. There's teams over here that are going to be with you. Okay, Michael, is there any particular reason why you don't want to come? Okay, Michael, I understand. I understand that safety might be at stake. How about we send you a crisis resolution home treatment team? We have the same specialists, especially psychiatrists, medical team, specialist therapists, all are going to come to the comfort of your home. And you will feel safer with them. Does that sound fine to you? Does it sound like something you want to do? Okay, thank you, Michael, for agreeing. And thank you so much for opening up. Once again, Michael, you're quite worn out by this situation. And I want you to know that us, the medical team, we are all here for you at any time. If you ever feel too overwhelmed, things are getting out of control, call us immediately. We will be there for you. Okay, Michael? Blah, blah, blah. Bye. Okay, who would like to attempt? Everyone's
Can
like, oh
I
my God, my God. Okay. Aksa's like, bro, I have an exam coming up. This is no joke. I'm gonna do this. Let's do it.
Okay.
Match my
So,
tone.
okay. That's a good reminder. Okay. What was the name again?
Michael.
Okay, Michael. So, Michael, as per our discussion, okay, I'll start over again. Okay. So, Michael, sometimes when people are going through really tough times, their brain chemicals are disturbed, and that makes them see and hear things that are not there. Now, I'm not saying that you are lying. All I'm saying is that this is called psychosis, and this could be an early sign of a disease called schizophrenia. And are you following me?
Whatever.
Look, Michael, you look quite worn out by the situation. Now, we can help you with this.
How can you
So,
help me?
yeah. So, I believe that can you come to the hospital?
I don't
So,
think I'm sick. I don't know.
yeah. But if you come to the hospital, you'll feel a lot safer here. There will be team to take care of you and they'll help you.
How are they gonna help me?
Yeah, they'll treat you and they'll give you antipsychotics and that will make you feel really good. And you'll be a lot safe inside the hospital. How does that sound?
Because I don't feel safe. I don't feel safe stepping out of my house right now, doctor.
Okay, that's fine. That's fine. What we can do for you is that we can send a crisis resolution home treatment team to you who will take care of you while you are inside your home. So you'll
Okay,
get the treatment
as
and
long
you'll
as
be
they come to
safer.
my house. I don't want to leave my house. As
Okay.
long as someone can come to my house, do whatever the hell you want.
Okay,
I'm
that's
okay.
great, Michael. That's great. Also, I would want you to have this crisis card and you can ring us up anytime you feel like things are getting out of control. Anytime you feel like you have to use some knife or something, call us up. Somebody is there for you. You're not alone.
Very good. Okay, that's clap for Aksa, everyone. That was a perfect psychosis case. Okay. So Aksa is just significantly impressing me since the beginning of the class, guys. We need to learn from Aksa. Okay, we need to message Aksa like secretly, hey, can you be my partner for Plab 2, please? I know that I won't give you much benefit, but you will give me benefit. And then Aksa is going to be selfless and give everybody benefit, hopefully. Well done. So that was schizophrenia. Now we've learned a new team, a new term, crisis resolution home treatment team. Go ahead, Dr. Raja. Say it. What is this called? Wait, I need to hide it.
Crisis Resolution Home Management Team.
Very good. Okay, Summer, your turn.
Crisis resolution home treatment team.
Okay, then Summer, what is the team for unplanned pregnancy?
Actually, I have missed that.
You were
So
there, I think, no?
yeah, I was there, but I have missed that line.
Okay.
So
Summer,
yeah.
then tell me, if someone has employment issues going on, like they don't know what employment to find, where will you send them?
Occupational no, job seeker.
Who knows the answer to this? Aksa
Citizen
knows.
Advisory Bureau.
Very good. So know these
Okay.
things, guys. Okay, Aksa, what is the pregnancy thing?
A national unplanned uh, pregnancy advice society.
Okay, National Unplanned
Advisory
Pregnancy.
Service, I think.
Okay, Raja's like, bro, I know. Why isn't she asking me
Na-
this? Well done,
yeah, I
Raja.
think it's National Unplanned Pregnancy Advisory Service.
Okay.
Well done. Okay,
National.
Raja, then where do I go for where do I go for when I want to when I have a boyfriend who's 10 years older than me and I'm only 16?
Safety.
Safeguarding Services,
Well
Social
done.
Services. Yeah.
So you should know these basic things in NHS. Where do you send when this happens? Where do you send when that happens? What are these services? So that was all for schizophrenia. Give me just 5 minute prayer break. And so we will be back in 5 minute means literally like not more than 5 minutes. Okay, just give me 1 second. Okay, not 1 second, five. But guys, keep your brain active. I'm coming. Well done, guys. Thanks for waiting. Thank you for being patient with me. Thank you for bearing with me. Now, let's continue with our next. Now, let's go to the eating disorders because I feel like let's do them today, okay? Because they're not that big of a deal. So, one case in psychiatry where it's going to be a little difficult, that's more chances for you to fail, is usually psychosis, but not no longer. All of you who has attended this will never fail the psycho. You guys are one of those handful of students that passed this case, and you guys have learned the right way, so you don't need to worry about it now. Okay, the ones that did not attend this class, they definitely need to worry. No offense to them. And the ones that are watching recorded, you didn't get to practice, so ha ha ha. Okay, I'm so rude. So live classes are always more beneficial. Okay, coming to the next are eating disorders. Now, eating disorder, bulimia. Who will tell me the difference between bulimia and anorexia?
BMI?
I will mute my phone because I'm the most distracted person in the world. Go ahead.
BMI?
I'm so sorry. You guys are on mute. I'm sorry. Sorry. Now speak. I can. Now yeah, please. Say it again.
BMI
Somewhere.
can differentiate this.
Okay. That's your. Okay. That's true. It's true. BMI can differentiate it, but what is the difference between the two?
Yeah, so in bulimia, those people do eat, but they eventually throw up. And
Very good.
the people with the anorexia, they just don't eat.
Well done. So it's the difference of a B, guys. It's a difference of a B. B for binge eating. Okay, so where anorexia does not have that, this guy has it. Bulimia says, listen to me, honey. I will eat my share of food. The difference is that I'll just vomit it up, okay? Because I want to enjoy life too, okay? So anorexics don't even want to enjoy a little bit basic of life, okay? So that binge eating is the situation. Okay, now the two ways, the two presenting complaints of bulimia anorexia will be either weight loss, and always usually the patient will come with usually bulimia they have some insight. Anorexics don't have an insight. Anorexic will usually come with, they usually come with their moms, okay? And this is a very teenage syndrome. So teenage problem, a teenager will be in front of you. So these are like some things that you can tell just by the look and appearance of the person that what this case might be. Okay, and they, don't worry, it's not going to be literally, guys, don't expect don't, please don't think that just because, like, for instance, in mocks, we are like the examiner in mocks, so we literally pretend to be the patient. So even if it's like a young, an old girl, like 60-year-old, but I'm sitting in front of you in a mock, it's not like that. In Plab 2, they hire proper actors, proper aged actors. So if it's a 60-year-old, there'll be actually a 60-year-old man sitting in front of you. Simulators are always actual, perfect to the case. So whenever you see a teenager sitting with you, not with you, in front of you. So obviously, if you're giving a mock and I'm sitting in front of you and I'm a 60-year-old, so it's gonna be weird, right? But when you go into Plab 2 and you see a girl like me sitting there, yeah, doctor, what's up? So you will know that this is most likely either diabetes, bulimia, or what are other things that like teenagers are usually diagnosed with. Suicidal attempt, you get what I'm saying? So usually teenagers have a handful of situations going on. ADHD, yeah, because teenage will be when you will be diagnosed with it. Okay, so that's why basically, if you guys know about the Lovan, the teacher Lovan, right? You know what's so special about him? The reason why he's so like talked about is because he does something that we're not allowed to do, like which that's why even I can't even say some things, right? So it's like you're not allowed, it's like a rule, it's like by NHS, it's like a law that you're not allowed to speak about your Plab 2 exam after you're done with it. I'm not allowed to tell you which cases I had in my exam. I'm not allowed to tell you how it was. So even with care, I have to say things. But with the Lovan, the reason why people like him, because he tells you the truth and he's not scared of anyone. Okay, so he tells you that whenever a girl who is 15, she's sitting in front of you, it's most likely this or this. So most likely these days a girl who's anorexic is coming, so then you have to do this. Okay, so basically it tells you exactly how the case is going to come, and what they'll be like, they'll be like this age, they will be wearing, like, not obviously you wouldn't know what they're wearing, but like, he'll tell you the clues. Look out for this. If there's a guy, young, middle-aged, he's just like sitting like this, like with a limp, then always go for this disease. So he tells you exactly, and that's all he discusses in his class. This comes, then this means this is the case. So he basically gives you the cases or whatever. That's why he's so famous, because everyone's like, oh my god, he tells you the exam. Okay. So anyway, I'm not allowed to do that. Like, my GMC license can be taken away from me if I do that. So I can't really tell you that this case came to me and it was like this. So hopefully this it stays within UK Pass, whatever I'm talking about, so I'll be safer. But there are a lot of things that I still have to hide from you to be safe. I'm also being a safe doctor. So let's talk about teenagers sitting in front of you. And what's going to happen is, this is also kind of wrong, me telling you that it's going to be a teenager, but obviously it's a predicting thing. So, but the truth is that everybody knows that everyone, even the notes, have these cases as teenagers, 16-year-old. But I think all of that is unethical according to NHS or whatever. So bulimia and anorexia will come to you. Teenager, mom is saying, doctor, she's vomiting. And then when you talk to her, your first question is, I can see from my notes that your mom has brought you in because you're vomiting. So first thing, what did I tell you guys? Always ask her, is it the truth? Are you even vomiting? Like, what the heck is going on, right? So could you tell me if that's true? Are you vomiting, Susie? Yes, doctor. Okay. And how often do you vomit? It's been going on for a month now. So you are probably thinking it's a GIT issue. It's like let's go to the GIT, what do you call it, structure. But my advice to all of you, or my biggest hack to all of you, is ask this question. Every time teenager girl comes to you with vomiting, or teenage girl comes to you with her mother who's saying that she's losing weight, always ask, the first question is intentional. So, Susie, was this vomiting intentional or unintentional? And that is how you bridge the awkward gap on how to tell her, how to make her say that I am making myself vomit. So that's what majority people struggle with, is how to make her spill it that I'm vomiting myself. Okay? Because otherwise, if it was a physical condition and someone's mom brought them, most likely it was a pediatric case because the kid was helpless, he doesn't know how to thought. Why would the mom bring? Why Susie herself will also be like, oh, doctor, yeah, I'm vomiting. It's so bad. It's been happening for so. Like, Susie will run to you. Why would she need her mom to bring her, right? So that's why this is most likely a case of AB, anorexia or bulimia, one of the two. So you're gonna ask her, was it intentional or unintentional? She's gonna be like, doctor, it was intentional. The moment she says that's the golden word, you come to this structure. This is your structure that you're gonna follow now. Oh, okay. And is there any particular reason why you're making? That's the first, guys, literally. What are the curiosity questions that come into your mind when someone tells you, I've been making myself vomit? First question comes, why? Why are you making yourself vomit, right? So ask her that. Don't be afraid to communicate what you're feeling. So, oh, Susie, why do you make yourself vomit? Is there any particular reason? Doctor, I want to lose weight. Okay. And have you been successful? Have you lost any weight yet? Yes, doctor, I've lost 10 kg or whatever. No, I haven't lost. Okay, that doesn't matter. Susie, but is there any particular reason why you're wanting to lose weight? Is there any role model you have, perhaps? Doctor, yeah, I have a role model or whatever it is. I want to be 40 kg, doctor. Okay. Oh, and I'm sorry to ask, but apart from how do you make yourself vomit again? Doctor, make myself gag and do it. Okay. Is there anything apart from vomiting that you're doing to make yourself lose weight? Perhaps any over exercising? Perhaps any pills you're taking? Some people actually take some pills to make themselves thinner, like diuretics, like semaglutide, like hoods, like they'll prescribe themselves. Like they won't go to a doctor, they'll just start taking pills. Okay. And now comes to the SCOFF questionnaire. So for anorexic bulimia cases, NHS says that do the SCOFF questionnaire to diagnose this. So the diagnosis can be done within the GP clinic by asking SCOFF questionnaire. Okay. If the score is more than or equal to 2, she definitely has an eating disorder. So what are you going to say? S for sick, C for control, O for 1 stone, F for food, and F for fat. How do you ask these questions? You guys are going to make up the dialogues, okay? So first is sick. Do you make yourself sick when you feel uncomfortably full? Yes, doctor. And this would be a good time to rule out bulimia. So, do you ever have any kind of episode where you make yourself eat a lot? Yes, doctor, or no, doctor. So, here you can rule out bulimia. Okay, Susie, can you tell me, would you say you have lost control lately over how much you eat? Anorexic will probably say no, but anorexic might also say yes, because anorexic will be like, I feel like I eat a lot, although she's eating nothing. She'll be like, doctor, I eat a lot. Yeah, I feel like I've lost control over how much I consume. I used to take like, I used to try to eat one bread before. Now I take one bread and one egg. I've lost control on how much I eat. Okay. Next, would you say you have lost 1 stone? What is 1 stone? How many kgs is 1 stone? How much?
I'm not sure, maybe between 60 and 63 kg.
Okay, so it's 6 kg. Okay. You were close. So would you say how much weight have you lost in the last 3 months? You can ask like that. It's up to you how you want to ask. Don't be like, have you lost 6 kg in the last 3 months? Don't be too like obvious about it, right? So would you say, what if she says, yeah, doctor, I lost 15 stones? Okay, no, she'll never say that. Or why is she existing if she has 15 stones? Okay, would you say you consider yourself fat, although others call you thin? This is the F question. And finally, F, would you say that food dominates your life? If she says yes to at least 2 of them, then it's diagnosed case. In the GP, you can diagnose an anorexic bulimic. Okay, who's going to tell me the scoff questionnaire? Go ahead, scoff. Scoff.
May I?
Hmm.
Okay. So, first of all, do you make yourself sick when you feel full and you feel uncomfortable? And then, do you believe that you have lost control of your eating? And have you lost a stone in the last 3 months? A stone weight. And then, do you believe that you are fat while other people are calling you thin? And
Well done.
do you think that food dominates your life?
Very good. Brilliant. So now listen to me, guys. It's not necessary you ask S, C, O, F, F. You won't maybe not that much time, at least 3 even if you ask, and you get 2 score already. So you know that you need a minimum of 2 score to
Mm.
diagnose. So it's even fine like that, because usually you won't get time to ask every single thing because you have to take care of the time. But then, by the way, this was just a memorization. So obviously Iksa wasn't doing it like she's doing a case. So however, if you are doing a case, my advice is even ask 2, 3 things. Even that's enough. Like fat while others call you thin, sick, 1 stone, enough. Okay. Now, Susie, I can see that this has been really weighing down upon you. Like, you're trying to lose weight. Can you tell me how? I'm sure you're 16, right? So you probably go to school, is that right? Yes, doctor. Have you faced anybody said anything to you, maybe perhaps any bullying that you want to lose your weight? No, doctor, nothing like that. And how are things at home? Is your family understanding? Yes, doctor. Okay, then do you have any role? So there are basically 3 triggers of anorexia bulimia. One of the 3 is happening to her. Either her family is the problem, maybe like family has like a broken relationship or something that's causing her, or it could be in the school she's being bullied. And the third, she just has role models. She's under a significant peer pressure. Okay, so these things you need to ask her triggers. Okay. All right. Now, what is the damn red flag in a case of anorexia bulimia? What is the damn red flag? Why do I have to use bad language for this? But like to exaggerate, I have to. Okay. You have to check that is her anorexia bulimia getting to her physical health or not. Okay. So, yes, you can ask about self harm, but a better red flag would be to ask what if her not eating is leading to her physical health going crazy, like nutritional deficiency, severe anemia, maybe her blood is at 3 hemoglobin and she can die in a minute if that happens. Okay, so Susie, would you say how's your physical health like? Have you experienced any maybe lightheadedness lately? No. Okay, how about any blacking out? Okay, how's your general health? Are you feeling good? Yes, doctor. Okay, and how about your periods? When was your last menstrual period? Doctor, I had it like 7 years ago, okay, or like 7 months ago, because usually anorexics, they have amenorrhea, okay? Now, coming to what you do in the examination part. So the structure goes like explore the complaint, always ask intentional or unintentional. If the vomiting is the complaint, ask about weight loss. If weight loss is the complaint, ask mode of weight loss. When she says mode of weight loss, she will admit to vomiting, making herself vomit. Okay. And then coming to SCOFF questionnaire. After SCOFF, you ask triggers, and then you can ask about red flag and end the case. Now you tell her, I would like to have a look at you, which will involve me doing your number one, observations, including your heart rate, blood pressure. In addition, I'd like to have a look at you from head to toe. And I would like a bedside test in the form of height to weight ratio and ECG. And then she'll hand you over the clipboard. BMI will say, who knows the normal BMI?
18 to 29?
Very good. So almost 19 to 25. Wait, what? Why did I say very good? That was completely wrong.
That
I'm
was
sorry. Sorry, but it sounded like you're going to the right. So it's 19 to 24.9 basically. Okay. Not 29. So below 19 is underweight. Within this is good BMI. You don't need to lose weight. You don't need to kill yourself. From 25 onwards to 25 to 30 almost. Let's keep it simple. So it's actually 29.9. That means you are overweight. And 30 plus is always obesity. So in anorexia, bulimia, either her BMI will be in the regular range or it will be below it. So whenever it's in the regular range, that's another sign, as Summer said in the beginning, that's another sign that this is a bulimia. Bulimia is usually because she's eating too, right? So she probably will fall in the right BMI. Anorexics are usually under 19. Okay, if her ECG is wrong, if her vitals come wrong, like wrong as in like bad, that means you need to admit her to the hospital. Okay, thank you so much for talking to me, Miss Susie. So from what you are telling me, Susie, I need to tell you that, the fact that you're making yourself vomit in order to lose weight, Susie, I need to tell you this, but this is a type of eating disorder. To me, it sounds like you are having either anorexia or bulimia. Let's talk about anorexia first. Seems like this is called anorexia nervosa. First, tell her it's an eating disorder. Or if you tell her anorexia, she'll say, what is it? You'll say, it's an eating disorder. Make sure the word of eating disorder is there. Okay, it shouldn't be it's a mental health condition. Just say it's eating disorder. That's a better way to say it. It's a type of eating disorder in which, as you mentioned, that people tend to think that they're not the right weight. Although, make sure you tell her BMI. So you have to have the BMI chat with her. So Susie, let me tell you, basically there's a measure of us checking if your weight is falling in a good healthy category. We call it BMI. It's the height to weight ratio. Are you following me? So your height to weight ratio has come out to be completely normal. So you're not overweight. You are not even obese is a far off thing. You're not even overweight. Okay. So you are completely healthy. And I really advise that, you don't make your BMI go down, because being underweight is not a good thing. Are you following me? Yes, doctor. So whenever it's anorexia, you refer to specialist eating disorder unit. It's a routine referral. Whenever it's bulimia, you refer her to, I would like to give you a link of the self-help programs. These programs help you identify your patterns and break from them. In addition, since you told me your mood is a little low, I will also refer you for CBT. So talking therapy is your safe word. When you don't know what to do, just refer to talking therapy in psychiatry. Whenever something's wrong with someone, just send them to talking therapy in management, because talking therapy is like no problem. Even if you send them for no reason, they'll be happy. Everybody needs some degree of therapy in their life. No offense. And then the only time where red flags are positive, we all know the basics of management. Red flag positive, simple as that. Go to the hospital. Don't like show me your face again. If you want, you can even refer these people to dietitians. So who's going to give me the management of anorexia? Because management is where psychiatry is a little difficult. Okay, someone open their mic and manage me. I'm a Susie and I'm an anorexic. Sorry, bulimic. I'm kidding. I'm not bulimic. I'm sleepy. Just kidding. Who's going to try? I'm Susie and I'm a bulimic. And I need someone. I need a doctor right now. And I want them to tell me what they're going to do.
Can I?
Go ahead.
Okay. So, Susie, as per our discussion and as per my examination, I suspect that you have a condition called bulimia nervosa. Have you ever heard of it?
No, what is that?
Okay. So it is an eating disorder, and where you tend to eat where you tend to binge eat, and then you eventually throw up. And I would want to emphasize here that you don't need to lose weight at all. I checked your height to weight ratio, and it's completely normal. You're not obese at all. So you don't need to really lose weight. So for now, I'm going to refer you to a self-help program where you can learn methods how to cope with it. And I would also like you to enroll with the talking therapy. Those sessions really tend to help people. How does that sound?
Oh, you care about me. Ah, thank you for finally asking me how does it sound. Yes, doctor.
I was thinking of it. I'm not even involving the patient. Getting a longer. The speech is getting longer.
Mm. No, no, it's fine. It's fine. Otherwise, whatever she said was
Hmm.
perfect, except the fact that she didn't follow the like every time, guys. It should be like a
Hmm. Hmm.
sin. I will
Hmm.
fall asleep if you guys do that, just so that you guys
Hmm.
know
Hmm.
that, oh, I can't let this patient fall asleep. It's going to be a conditioned response. Okay, I'll make a conditioned
Hmm.
response to you. Conditioned responses, every time you're going to speak too much, I'm going to fall asleep. So that in Plab 2 exam, you'll never do that sin.
Hmm.
So you're telling her the diagnosis.
Hmm.
Are you following me? Would you like to hear about what we'll do for you? Are you following? Yes. Okay. First treatment is self-help program. Are you following me? Yes. Okay. In self-help program, this happens. Does that make sense? Yes. Then the next treatment is CBT. How does that sound? In that, this happened. Does that make sense? Like so many times you have to keep it a
Hmm.
conversational. Okay, very good. So we're done with, okay, so bulimia is self-help program, anorexia is SEDU, and if any emergency, you just send her to the damn hospital. So this is how simple you need to keep Plab 2. Don't keep it like, okay, in anorexia, we have to refer to the specialist eating disorder unit where there will be a dietitian and some people that are going to be similar to her so that she doesn't feel that much. So you don't do that. Just remember big fat things in Plab 2. Big fat things will help you, not minor details will only help you in written exams. Yes, Dr. Kuye. I think that was by mistake, no problem. So in in oh, I forgot. In Yeah. So in exam, the more detailed you remember, that is not a Plab 2 hack. For Plab 2, you should always keep it simple. Your brain should literally be a mind map. This is how your brain should be. Your brain shouldn't be full of like pages and books and 20 million. Guys, I literally forgot what I was saying. Anyway, so you get what I'm saying? So we're done with anorexia and bulimia. Like the most difficult cases, psychosis and bulimia are out of the way, thankfully. So let's talk about the final part of psychiatry. Yes, Kuye, please.
Yeah, sorry. Yeah, I just went up the. Well, I have a question. In
Yeah,
the when we started eating disorder, you were trying to differentiate between bulimia and anorexia.
yeah.
So, but I didn't get it.
Okay,
I didn't get which one I have. Maybe we can just go over it. And
okay,
then
okay.
what is this referring to SCDU? I didn't get that too.
Okay. So
In
firstly, how do you
anorexia management. Thank you.
got it? So when you want to differentiate between anorexia and bulimia in the form of questions, all you need to ask is, okay, in the sick part where you're in the SCOFF questionnaire, you should be like, do you make yourself sick when you're uncomfortably full? Yes, doctor. When she says yes, then you rule out bulimia. You say, okay, would you say you have, times where you eat maybe excessively before you vomit? Okay, so it doesn't necessarily have to be in the sick part. You can put it anywhere. You can put it in this part. See, overeating. You can ask, so just for bulimia, make sure there's an extra question called about overeating. So you're gonna ask her, so Susie, and do you have any kind of maybe particular times where you might eat excessively? Does that happen? Or is it always no? Yeah, doctor, I have excessive, I eat 5, 6 burgers. Okay, that's a bulimia, honey. Second thing is anorexia is referral to specialist eating disorder unit. This is where there's going to be like people, like a therapist will be there. They're going to be looking after you. They will help you identify patterns, same thing. And they'll tell you about your disease. They'll educate you about it. And then they'll just give you some, probably some therapies to break from those cycles. Get it? So anorexia is more dangerous than bulimia because anorexia, they're not eating at all. So that's why you refer them to eating disorder unit. For bulimia, you can just tell them there's an online self-help program, enroll in it. And then we will follow you up and see how you're doing. If you require, then we'll further proceed with eating disorder unit if that doesn't work for you. So now let's go to the MMSE. Patient will present to you, doctor, I think I'm becoming forgetful lately. Guys, just let me warm this this stimulant up. Otherwise, my brain won't be warm enough. Okay, give me 2 seconds. Thanks for waiting. So now let's talk about the final part of psychiatry and let's get this CRAP over with because I don't want to say more bad language words. Okay. So the thing is that, guys, here's the plan. The abuses are also coming in psychiatry where someone comes with heroin overuse, alcohol overuse, but it's totally fine. We have many days with me. So I can fit these two some other day because right now I think almost time's up for the class, right? Because now I have to be like, okay, that's it because SPT needs to start soon. So that's why let's just finish it with the MMSC because we've done the most important thing of psych. I'm so excited. Anyway, MMSC, honey, dementia first. First, someone tell me what the heck is dementia. Guys, remember your concepts. If they're not clear, then you can't go proceed further in your profession or whatever it is in life. Make sure your concepts are strong and your foundation is depth. I don't know what I'm saying. Okay, who's going to tell me what is dementia? What's your concept? What's your concept of dementia? Like, what do you think it is? I know
Memory
someone's
loss
Google.
due to
Exactly.
memory loss due to loss of brain tissue.
Well done. So see, majority have the concept that dementia is a memory loss, right? So well done. That's actually not wrong. But I'll tell you the truth about the concept of dementia that I want to change. As a doctor, we should know the depth of the explanation. Is that dementia is not just basic memory loss. Dementia goes in stages, like it gets worse with time, beginning with memory problems. So yes, Zara's right. Her brain is slowly with time, with age, dementia is usually caused by age. Okay. So with age, your mental function starts declining. There's atrophy in your cerebral tissue. That atrophy, you know what it causes? It starts affecting all the brain centers, beginning with memory, but then all things start to get involved. No wonder people are like, why is she dying with dementia? It doesn't make sense. I'll tell you why. First, it begins with just forgetting things. Slowly, it comes to the point where you forget even basic tasks. You forget to take care of yourself. And then you get infected, you die. So you stop caring about yourself. You forget your, like, it's not like a proper memory loss. It's like, you have relative, this is my daughter, this is my son. But slowly your cognitive goes decline. Like, you don't care about them anymore. They're like, okay, get out of my face. Like, you start losing your inhibitions. So all of these centers are controlled by the brain, and all of these are declining. So you'll lose your inhibition, you'll become insensitive, although you don't mean to do it. You don't mean to do. It's not like you're becoming a bad human being. No, you're the center that controls it is declining slowly, right? So it begins with memory loss. Doctor, I become forgetful in familiar places. Like, I can't find the way to my house sometimes. Sometimes I forget names. Sometimes I forget my functions. And then slowly it goes to, oh, I forgot to take a shower. Oh, why am I disgusting? Like, they forget to take care of themselves. So then they need carers. They need someone to come and tell them, come, we need to go eat. Okay, we need to put food in your mouth. Okay, food in your mouth. So I'm gonna sleep now. No, honey, you need to brush your teeth. What are you doing? Oh, sorry, I'm dementia, na. Okay. So then eventually it goes to a point where their inhibitions also stop. They're rude. Get out of my face. Oh, you're gonna do it in front. So they're gonna start saying things that are very inappropriate, and then they start like hating on their own children, but it's not their fault, it's the brain that's declining, so you have to excuse them. Okay, now you understand what is dementia. What are the early signs of dementia? Memory loss. So us as a junior doctor in the GP surgery, all our duty is to identify that this is early memory loss, might be dementia, can be other thing, refer to memory clinic, that's it. So all managements are refer to memory clinic only if they have the memory loss. Now, second thing is that it can be another thing called, what else can be memory loss be a caused by? One disease, guys. How can we forget our favorite disease? No offense.
Parkinson's?
Not like Parkinson's is not exactly memory loss. Memory loss.
Alzheimer's.
Delirium, maybe.
Alzheimer's, yeah, yeah.
Raja, yeah. Alzheimer's. Okay, so obviously Alzheimer's is
Mm.
a proper disease that is like memory loss is the main what do you call it, symptom of this disease. For dementia, there are other things also that are there, but for Alzheimer, it's all about memory loss. Literally, that lady one day will be like, "Who is she? I'm your daughter. How can you not recognize me? Oh, sorry, I have Alzheimer." Okay, so in dementia, like the person still knows that okay, you're my daughter, but I don't give a crap about you. Get out of my face. But in Alzheimer's, she's completely like, bro, who the heck is this person? I've never seen her in my life. Okay. So, second thing is the third thing, who said it? It was right. It was correct. Raja, I think, said it. Yes, it was you. Raja knew I was talking about her.
Yeah, I was
Parkinson,
talking, and then when you said Alzheimer's, I'm like, oh no, maybe I said the wrong thing.
you
Yes.
didn't say
Okay.
wrong.
Okay.
Parkinson is also a form of declining mental function. Okay. So Parkinson also begins with Parkinsonism feature, which are like loss of movement, loss of facial expression, slowed down everything. But slowly, the brain goes into so much decline that also memory loss can happen. Okay. And there are many other causes for dementia. Sometimes it's stroke. After stroke, also you can call dementia, called vascular dementia. But those are things for Plab 1. We don't care about knowledge. For us as junior doctors sitting in front of patient, our responsibility is very simple. Does she have memory loss or not? Yes, refer to memory clinic. Bye. Okay, that's it. That's why I say Plab 2 is simple. Let me show you now. To diagnose if whether it's our Alzheimer, Parkinson type of dementia, that's neurologist work. I am a junior doctor, thankfully. Okay, I only give Plab. I'm not an MRCP. I'm glad I didn't give MRCP because this is too much knowledge. Okay, so what are the questions you'll ask for someone who says, Doctor, she will present to you with, Doctor, actually, my daughter tells me that Sometimes I forget, to do things at a certain time. So I'm kind of concerned, what if I have something going on? So they usually present telling you that we are forgetting things. Okay. So what are the what are the elaborating questions upon forgetting things? So you say, oh, okay, how long has this been going on for? How long has it been going for? Our favorite OD para question, D part. How long has this been going on for? Has this ever happened before? Okay. Can you tell me how forgetful? Do you have difficulty identifying familiar faces? Yes. Would you say that you get lost maybe when you're going out? Yes. Do you think you get a little clumsy with day-to-day tasks? For instance, turning off the stove might get difficult for you. Maybe brushing teeth becomes forget. Yes, doctor, this is what I've noticed. Sometimes I forget to cook food for myself and I'm like, wait, what? I was supposed to eat, okay? So it can be anything. And then you rule out the DDs. You go for two DDs. We've already talked about Alzheimer and Parkinsonism. So Parkinsonism, you're going to ask, so have you noticed any kind of maybe shakiness of your hands? No, doctor. Okay. Is it easy for you to walk and move, or have you noticed any kind of stiffening? No, no, nothing like that. Okay. And Alzheimer, the only way to rule out Alzheimer is family history. Okay. Could you tell me if anybody in your family has similar issue? Oh, yeah, my mom had Alzheimer's disease. Okay. The problem with the scenario of dementia or like memory loss is the performance part. Questions are very easy. Now, what you have to do in this time, you have to tell them, I would like to perform a mini mental state examination. And that's where you're like, crap, how do you do that? No one warned me of this. Okay, so there's a mini mental state examination. I made it easy for you. All you have to do is you actually have to perform this. So you have to be very careful that quickly end the history quick. So this is more like an examination station. You have to keep your history a little shorter than normal because there's nothing much to ask, right? And then you start. So you have about 30 points and you have to see how much is the cognitive decline. Okay. Total is 30 for this entire questionnaire. Okay. Sometimes they'll give you the questionnaire. Sometimes you'll have to do it off the top of your head. So it's very easy. First part is time and place. Second is the world of three. And third is the OET. First part is the time and place. You get 10 points, 1 point each. Okay. Okay. Maria, I'm about to perform a mini mental state examination on you just to check the status of how your brain is doing. Will that be okay? Yes, doctor. Okay, first, could you tell me what year is it? So in this, always remember 5 questions related to time. Beginning with the outside, coming inside. So outside, year. What is the year? Okay, what is the month? What is the day? And what is the date? And what is the time? So it should be, doctor, it's 2025. It's May. It's day is Wednesday. Oh, sorry, Tuesday. Shoot, I have cognitive decline. It's Tuesday. The date is 27th. And then the time is evening time or morning time, whatever. Okay. So if she answers one thing wrong, you minus her score minus one. Okay. So in this, I teach my students, don't add on the score, minus the score, keep record of the minusing score. That will make this easier for you. Okay. Then comes world of three. World of three goes like, okay, Maria, I want you to remember 3 things that I'm going to say and repeat them after me. Apple, table, penny. She'll say apple, table, penny. Every time she says the right, you give her 1 point. So once again, don't count her marks that are adding. Count her minusing marks. If she says apple, table, I forgot the last, -1. Okay, from 30. Okay. Now what I want you to do is, Maria, spell the word world backwards. She'll say D, you get 1 point. L, you get 1 point. O, you get -1. R, W. Okay, so she has to spell it backwards. Okay, Maria, now I want you to recall the 3 things I told you at the beginning. Oh, yes, doctor, it was apple, it was table, and it was a shoe, -1. So -3 up to now. Okay, now coming to OET. First, you check why is it OET? Because OET is an English exam. It consists of speaking, listening, reading, writing. That's exactly what you're going to do with the patient, or IELTS, you can call it. Okay. So speaking, how do you test for speaking? Could you tell me what this is? Doctor, it's a pen. Okay, and what is this? It's a paper. So she's speaking. You're testing her speaking. What is this? It's a paper. Repeat after me, Maria. No ifs, ands, or buts. Okay, doctor. No ifs, ands, or buts. You get 1 mark, 1 mark, and 1 mark for all three. Coming to listening. Okay, Maria, what I want you to do is do as I say. Take the pen, fold the paper, and put it on the table. If she does all three tasks, 3 out of 3. And finally, you're going to say reading time. Okay, Maria, I'm going to write an instruction on this paper. You write close your eyes. Okay, write close your eyes. I want you to read and perform what is written. So it says close your eye, and she'll be like, okay. And she'll close her eyes. If she closes her eyes, 1 point. Now, Maria, what I want you to do is now you write me a task. Like I wrote you close eye, I want you to write me a task. She will write something down and you'll see, okay, her writing also good. Then you'll say, okay, now Maria, I want you to draw this. You're going to draw this for her and you're going to say, copy this image that I drew. So it should be double pentagons. And if she draws the same, she gets 1 mark. Okay. So overall, this was time and place. I forgot to tell you place. Place is what country is it? UK. What state is it? Manchester, sorry, England. What city is it? Manchester. What building is this? Hardman Square. What floor we are in, and she'll know 8th floor or whatever. So this now, what I teach my students is that keep record of the minus marks. So total is a 30. From 25 to 30, even if she got minus 3 marks, she's still at a normal cognitive function. She doesn't need any memory clinic. But if her score is minus 7 marks, many mistakes, you'll say it's a mild. So anytime her marks come less than 5, doesn't matter if it's mild, moderate, or severe. If at less than 5 her score comes, like she loses more than 5 marks, you have to send her nothing to the memory clinic. That's all. The management is easy, but the MMSC is a little difficult. Who's going to do the MMSC? Come on. Highlight the important points. Last thing to memorize today.
Can I?
Okay, Aksa.
Thank you. And please allow me to say this is such a smart way to remember, because earlier I was trying to cram and cram and cram and I like kept forgetting. Thank you. So
You're welcome.
let's see how much this has helped me. So first of all, it has 3 parts. And like, should I like go as in I'm talking to a patient?
Yeah, go as you're talking to patient.
Okay, that would be better. So Husna, would you please tell me what year is it?
It's 2025.
Okay, what month is it?
It's May.
Uh-huh. And what day is it?
It's Sunday.
Mm-hmm. So, what date is it?
It's maybe like 1st of the month.
Uh-huh. And could you please tell me what time is it?
It's like it's in UK it's freaking 2 p.m. or something.
Okay, great. So, could you please tell me which country are we in?
Oh, we're in United Kingdom.
Great. And what state is it?
It's England,
Mm-hmm. And which city are we in?
Manchester.
Uh-huh. And what place is it?
We're in the Hardman building,
Uh-huh. And what floor are we on?
3rd floor or something.
Great. And could you please tell okay. So now I'll tell you 3 things and you have to repeat after me, okay?
Okay.
Okay. So say apple, table, penny.
Apple table penny.
Great. And would you please spell the word world backwards for me?
Yeah, it's D and then it's R and then it's L and then it's O and then W.
Okay. So could you please read this sentence for me?
What sentence? Read it for you? What?
Um, oh, sorry. I got distracted. Okay, sorry. So would you take this paper and follow what I have written on it?
Okay, wait, you're missing something. You're not done with the world of 3 yet.
And apple, table, penny, and then world backwards.
And then
Recall.
Do
Now
we
tell
make
again
them
what.
recall the Apple table penny?
Yeah,
Yeah.
I think, yeah.
it's
So,
okay.
Husna,
Tiny mistake.
earlier I told you three things. Could you please recall them for me?
Yeah, you said Raja, Aksa, and Zara.
Okay. So, um, okay. So, where am I?
Now you go to
So,
OET.
yeah. So, Husna, now please take this piece of paper and follow what I have written for you.
You've written in it?
Uh-huh.
Okay. Okay.
Oh, great. Now, would you write a meaningful sentence for me?
Yes, I would love to write. Writes down the perfect thing in the world. Thank you so much.
Okay, great. Would you repeat for with me? No ifs, and but.
No ifs, ands, and but.
Okay. And what else? What else? What else? Um, um,
What is this?
yeah. Would you name this thing for me? What is it?
Oh, it's a pen.
Oh, great. And what is this?
It's a paper.
Great. Are we done?
You have to draw.
Oh, yeah. So, Hosna, would you draw this shape for me?
Blah, blah, blah. Okay. Now, what do you think is how did I perform?
I subtracted 5, so it's severe cognitive decline.
Severe? I don't think I made that many.
I subtracted 5.
Oh, you subtracted 5, so it's mild, right?
Okay,
Okay. What matters is there is a cognitive decline. Yes, it does
okay,
seems like there's mild cognitive. We have to refer you to the memory clinic. Same
okay.
thing for everything. Okay, so if you subtract more than 5, thing is that you
Mm-hmm,
have had decline. If she does
mm-hmm,
severely bad, like everything is wrong, then obviously you can say it's a severe cognitive decline.
mm-hmm, mm-hmm,
But if it's more than 5, you just say yes, definitely there's a mild cognitive decline, go to hell. Or don't actually say that. So what I was trying to
mm-hmm,
say is that, yeah, so now let me make you memorize OET once again. So in
mm-hmm,
OET, first thing, always go sequence wise. Don't be like first writing one part and then speaking one part and then writing it. Get it? Stay in one. Speaking is pen, paper, no ifs, ands, or buts. Memorize that. Pen, paper, no ifs, ands,
mm.
or buts. Pen, paper, no ifs, ands, or buts. Go. What is speaking?
Pen, paper, no ifs, ands, and buts.
Very good. Come to the listening. Okay, I want you to do this for me, this, and kill yourself. And then she actually kills herself, and then you can perform the
Mm-hmm,
memory. Sorry, guys, that's it. That's how we end the lecture today. I'm just kidding. So, got it? So, you just ask her to perform something by
mm-hmm,
telling her. Next is so, reading. I've written something over here, perform it for me.
mm-hmm,
Okay. So, first, make her perform by telling her what to do, then make her perform by showing her. Okay.
mm-hmm,
So, first, perform by what I tell you, perform by what I write for you. Okay. So once again, let's go to the start. Pen, paper, no ifs, ands, or buts. Perform what I say, perform what I write. Okay. Now writing part is left. Now you tell me what to do. Write it down for me and draw.
mm-hmm.
Okay. Now go and tell me with your memory what you learned.
Okay. So, first of all, what is it? Pen and paper, and no ifs, ands, and but. Then
Very
I
good.
proceed to uh, I'll ask you to do something like close your eyes. Nahi. I'll ask you to take a paper, fold it, put it on back on the table, and then
Very,
I'll show you what to do.
very
And
good.
then
You
uh,
tell me.
now exactly. Now I tell you, and then you tell me. So would you write a meaningful sentence for me? And then I ask you to draw.
Very good. Okay. So if you guys can remember it like this. So pen, paper, no ifs, ands, or buts. Now I'll tell you what to do. I'll write what you need to do. And then now you tell me what to do and let's draw together. So memorize it like that. So this is the score. Let me see what Kuye is asking me. Summer is such a sweetheart. She's helping. What is OET? So OET is basically, what's her name? Kuye. OET or IELTS. It's basically like a way to memorize. The third part of the test includes you taking their IELTS exam or your English exam. So you assess them in 4 domains: speaking, listening, reading, writing. Okay. How do you assess them in speaking? By asking them to speak. Instruct them, like hold a pen in front of them and ask them, what is this? She will say pen, you give her 1 mark. Now hold a paper in front of her, say, what is this? She'll say paper, give her 1 more mark. And finally tell her, repeat after me, no ifs, ands, or buts. If she's able to say no ifs, ands, or buts, she gets 1 mark. Now, what you tell her in
Yes,
listening.
I understand the structure. I just wanted to know what the mnemonics mean. I get
Okay.
yes. So when do we
Kuye is
refer
like,
to the clinic?
okay, so this is what you need to see. So results are anytime, see 30 is the total score. If she is, I want you guys to keep a record of the minus score. So if she's having -3, she made 3 mistakes, she's still in a normal cognitive function. Okay. But if you know it's her mistakes are more than 5, means they're 6, then 100% all cases above 5 have to be referred to the memory clinic. And if you want to tell her what degree her memory loss is, then obviously if she has up to -10, she has mild. If she has up to minus 11 to 20, then it's moderate. And if she has very like nothing she's saying, maybe 2 things she performed right, then it's severe. Okay. So once again, time and place, world of 3, OET. OET goes like, what is this? What is this? No ifs, ands, or buts. Pen, paper, no ifs, ands, or buts. Now do what I'm telling you. Now read what I'm telling you. Now you tell me what to do. Let's draw together. And that's how you nail the MMSC. Okay. Sometimes, guys, what you do is you will proceed to perform MMSC, but maybe when you come to the state part, the examiner will be like, okay, stop. And the patient will give you a clipboard and give you the answer to the MMSC. Sometimes they actually do that. They just wanted to see if you know that I need to perform an MMSC. They're just looking. Okay, she knows when to perform MMSC. And they let you perform in the beginning to check, do you even know what an MMSC is? And while you're doing it, they might stop you and they'll just give you the score so that you don't have to go this far. So because we all know 8 minutes is not enough for an MMSC. Okay. So we're done with, oh my God, we're done with psychiatry. I thought it'd never end. The problem with psychiatry is feels like it'll never end, but like, well done, everyone. Well done for coming this far. If you were here with me since hour 1 to hour last, you are nailing that exam without doubt. Okay, in a month, no, in 2 months time, you'll hear Aksa say, I passed the exam. In September, you will hear all of the others say, I passed. And there's no way you guys won't pass if you go this way. Keep big things in mind, not tiny details. You don't have time for that. This is a consultation exam. So everyone, what I want to tell you is that the heroin abuse, alcohol abuse, will do it later. Okay. And then, yeah, SPT. Basically, if anybody's new, let me tell you what an SPT is. SPT is basically you perform mock with us, but it's very like friendly. It's like everyone's here, and I'll be like, okay, Zahra, do the psychiatry, like do the schizophrenia case with me, and there'll be an 8-minute timer. You'll perform the whole case, and the mentor will be judging you in front of everyone, and will be like, bro, fix this, fix this, fix that. So most likely, Dr. Zobi will perform it, and she will tell you, and most likely it'll be in psychiatry to check if you guys are applying what we did here. Okay, so mostly SBT is for testing you guys. Teaching is for me to teach you. And then SBT is to put to test what you did. So make me proud, okay? So tomorrow's class is with Dr. Azram. See the teaching schedule in the group, and that's exactly what it is. Okay, thank you so much for attending. Hello, Doc. My top student of the day is not 2 students, it's just 1, and we all know who it is. Well done, Dr. Aksa. You are the top student of the day. Sometimes some people do so well that there can't be a second person. You get what I'm saying? So well done, Aksa. From the beginning to the end, from yesterday rather, she's been here, active, answering everything well. And we all know the part that the reason I'm making her my top is because, wow, she praised me so well. I'm just kidding. Okay, so well done, guys. And Dr. Kuye, a shout out to you for being at work and still trying your best to attend and participate. Okay, Summer, shout out to you for having a kid and doing all of this, but you're staying here. That's what matters. So see you on Thursday for the next class, which will be, I think, medical errors. We will start ethical parts. Yeah, we will start ethical part of Plab 2 exam. Okay, thank you all for attending. Good luck and see you all. Any questions are welcome. You can ask in the group and stuff.